vestibular disorders are a very complex subject, and that is the reason we are having this unique program today. We are approaching vertigo not only from just one angle or one perspective, but we are trying to make it a truly multidisciplinary approach to solving the dizziness and the balance disorders. So we are combining the perspectives of ENT, neurology, psychiatry and general medicine. So over the course of the day, 5 experts will guide you through a comprehensive 360-degree understanding of modern diagnosis and management of the balance disorders. But we are not here only for the presentations. We are also going to have a hands-on session, which is the real highlight for today. And the session which you absolutely cannot miss. We are going to get direct practical experience with Kenneth repositioning maneuvers and vestibular rehabilitation therapy, and techniques that you can take back to your clinic tomorrow. Many of you are already familiar with American Institute of Balance, but I will just give you a brief introduction about American Institute of Balance, or AIB as we call it for short. So it is founded in Florida back in 1992 by Dr. Richard Gans. AIB has grown into America's largest multi-speciality network for dizziness and balance care, with over 2,000 research papers. They have been doing basic research into balance disorders and vertigo. So this is 2,000 plus papers are there to their credit. AIB is a global powerhouse in education, certification and evidence-based research, partnering with top-tier hospitals and specialists worldwide. In 2020, that global expertise officially came to India, launched by our very own Dr. Neha Srivastava. She is the director, as you know, of AIB India, and she will be leading the presentations, etc. today. So for those of you who know her work, Dr. Neha Srivastava is a brilliant consultant otologist and an ENT specialist. The director of AIB India, RTKL Diagnostics and RTKL Polyclinic. And she is the driving force behind the RTKL Vertigo and ENT clinic here in Mumbai. She is professionally affiliated with the leading international bodies, including the Bharani Society, the International Headache Society, and the British Academy of Audiovestibular Physicians. Known as one of the youngest and brightest minds in Indian neuro-otology, she has successfully treated more than 25,000 patients. But beyond her clinical practice, she is deeply committed to empowering the medical community, having trained 20,000 plus practitioners through AIB's advanced international certification program, around 35 webinars, and around 25 hands-on sessions, workshops, and CME events. We also have now introduced a brand new AIB Academy, which focuses on small batch mentoring, hands-on skill training. So unlike the other certification or the other courses which are more presentation based, this one is more of a practical experience, more hands-on. And this we have introduced only a couple of months ago. So today we are bringing that standard of excellence to this room. We have packed exciting day ahead, and a quick note, we have a small surprise for you before lunch, which we will reveal just before the lunch, so keep an eye for that. Without further ado, please join me in welcoming our founder director of AIB, Dr. Neha Srivastava, who is the first speaker of the day. Thank you.
So good morning everyone, and I'm happy to see the mixed crowd today, youngsters and senior people all together. And I believe AIB is the only institute probably in India which is bringing all the specialities together. Before I start today's session, I would also like to thank my guest speakers for the day, Dr. Bini. She made it today coming all the way from her busy OPD. Dr. Divya, she came from all the way from Nagpur, and of course I will be having Dr. Dinesh Singh, Dr. Suraj, and even Dr. Apeksha. Just for your information, they all are part of my team and they exist, and we collaboratively treat patients. So today whatever you are going to get or evidently add to your knowledge is going to be the part and parcel of our daily routine, and this is how we treat vertigo cases every day. So probably even if AIB is USA, AIB India has their own Indian protocols to be followed. So with that, I will open the session for today. Today's session of mine about approach to a case of vertigo is more about clinical thinking or how you should actually streamline your mind as to when you see a case of vertigo. It is not only the theoretical basis or a kinocilium or a tippling behaving with each other with the inner hair cells. It is more than that how you approach the patient and how you deal with them, or just you can just subset, you should just tell them no, it's the only functional component. So it is very much up to you, because you need to decide between the otological, neuro-otological, again neurological, mixed, psychosomatic or psychogenic cause of vertigo. So with this I'll open the session for the day, and my favorite topic is how do you approach to a case of vertigo, because it's a basic understanding on how you should actually go about. Okay, so as usual we all have some myths. We are commonly asked as a healthcare professional this following questions, that is our vertigo treatable? So majority of the time some physicians are of the opinion no, it will keep on recurring. Some good pharmacist or some good relative will come and feed your mind, it will not get cured, it will remain with you forever. So the answer is vertigo is treatable. Only if you channelize, if you know what diagnosis, where you are going and how things are getting shaped up to you. Recurrent, vertigo is recurrent, especially in cases of vestibular migraine or in Meniere's disease. You tend to have a recurrent vertigo. Also there is something known as recurrent BPPV also. Neurological or ear related, majority of the vertigos that happen is mainly from the ear, but remember one thing, that the entire balance system is not only responsibility of the ear. It is basically the brain, spine, foot, eyes and ears, they come all together, and that is how you maintain the body's balance. So ear related is going to be around 60 to 70%, 20% will be again neurological, and 20% can be a mix and overlay of the symptoms. Cervical spondylosis, how many of you believe that cervical spondylosis is a leading cause of vertigo? Please raise your hands. Some are fresh faces who have already attended my previous session, and I will keep on telling this thing. But on this side of the part, how many of you believe that cervical spondylosis is a cause of vertigo? You believe? And why do you believe so, ma'am? With respect to your seniority?
I've seen cases of cervical spondylosis.
Ma'am, what is the common complaint they come up with?
Vertigo.
Ma'am, but the common complaint of cervical spondylosis is pain. Neck pain. So cervical spondylosis is not a cause of vertigo, because we have three reflexes. One is vestibular ocular reflex, vestibular spinal reflex and vestibular colic reflex. So basically when they keep the collar for a very long time, which I am sure Divya is going to highlight about, we will come to know that it is the tonicity of the muscles that get lost, and that is the reason why, and the reflex which goes down, which is the vestibular ocular reflex, and the velocity of the head increases as compared to the eye, and that is why you get this kind of vertigo, especially in the movement. But when we talk specifically about cervical spondylosis, we are indirectly talking about vertebral basilar insufficiency, basically, which should have a neurological symptom, which Dr. Dinesh Singh will be speaking about. So I will not touch base on that, because I have a complete session to talk about in the hands-on. So we will discuss, but cervical spondylosis is not a cause of vertigo, so please get rid of that mindset. Okay? Role of medicines, yes, but not buffet of medicines. Unlike the buffet lunch, buffet dinner we have, it is not that we will keep on prescribing all the 4 beautiful drugs that we have. There are only 4 drugs. Beta-histine is there, chlorpromazine is there, cinnarizine is there, and meclizine is there. What is left? The change in the brand name. But things remain the same, and to add to that speciality we can add the doses. it is desirable to take it at 16, or is it desirable to take at 48, or is it desirable to 144, as some of the German researchers say. But try and understand that at a certain point of time the drugs are giving up, so something else has to come up, na? It cannot be forever. So what is that factor? So that we are going to discuss today. So the role of medicines are limited. Out of all the drugs that we are limited to 3 to 5 days. You should not actually increase it, or else you are inviting extrapyramidal symptoms or maybe inducing Parkinson's in that cases. So a patient who was coming initially with rotatory spinning, after 15 days will have more of imbalance and non-spinning kind of vertigo because of the vestibular suppressants. Now, when the drugs enter your body, they don't know whether they have to go to the right ear or left ear. Correct? Any of the antibiotics are aware if they want to go to the right leg or left leg? No. So they are going to go into the circulation. So once they enter the circulation, they are going to be entering both the ears. So suppose if hypothetically if I say if the right ear was actually getting affected, now because the drugs have been introduced, so if the right ear was affected by 30%, now because of the drugs for a long standing time, the drugs will further go down to, the right ear will further go down to 50%. And the left will also start going down by 20%. So naturally the patient will, the nystagmus will get suppressed on positional vertigo testing. And now you have something known as a new normal for that patient, or a new abnormal I would say, which is more of an imbalance. So the limitations of in peripheral vertigo is quite high of the drugs. So it is more about the rehab and the canalith repositioning maneuvers. Of course we will be discussing more about it as and when we approach. But these things you need to clarify at the starting of this session. Non-specific exercises, a lot of people or a lot of companies they prefer giving that paper. ये कर लो ठीक हो जाएगा. ऐसा नहीं है. Like your hearing has a system frequency. Your hearing frequency is assessed from 0 to 8 kHz of the cochlea. In the similar fashion, your balance system is also from 0.5 Hz to 6 Hz. You cannot expect a patient of imbalance to take a diving catch like Virat Kohli. Not practically possible. Because the balance apparatus and his the hands and the eyes reflex or the coordination is not up to that mark. So that need to be understood. So for that also, with the advent of neurotology in last 10-15 years, since the time we all started postgraduated and we went into the fellowship, there has been advent in neurotology. And such is the status that we can study the each and every part of the inner ear, and we know how to rehab also that patient now in a better fashion. So that old regiment has gone. Rand Daroff is gone. Cowthorne-Cooksey is no more. We have new protocols. Now what is introduction? Now introduction of vertigo is simple. Vertigo is an illusionary or a false sense of motion of the body or the environment, most often a feeling of spinning. Most often a feeling of spinning. But that doesn't mean the other three are not involved. Imbalance can be a part of vertigo. Tilting can be a part of vertigo. And swaying, like being on the boat, is a part of vertigo. And we differentiate vertigo into peripheral and central. Peripheral, when I say, it's all limited to the inner ear and the other organs, and central is more about the brain, spine and foot. So this is from Dhingra. All the ENTs there, they must be aware behind it. This has been taken from Dhingra, our graduate days. So from the external ear is right from the auricle to the tympanic membrane. Then in the middle ear we have the sound conducting mechanism with the 3 small bones. And then comes the inner ear, which is responsible for the balance. Now, when we talk about the balance, so we have 3 semicircular canals, 1 utricle and 1 saccule. So utricle and saccule are basically the otolithic organs we have, which has the calcium carbonate crystals within it, and they are responsible for the linear acceleration. Means all the straight movements, aage piche, sideways and up and down. So basically utricle is more about going ahead and sideways, and saccule is more about up and down movement. So these are linear acceleration, okay, straight movements. And the semicircular canals are with respect to the angular movement of the head. So for example, your x-axis is yaw, then the y-axis is pitch, and then there is roll. So when you are touching the shoulder, it is a roll, and yaw is just horizontal movements because they are on the x, y, and z axis. Okay. So when let's repeat it, x, and you move your head left and right. Okay, all of you all. Y is this pitch, this is anterior canal, and Z is posterior canal. So as I summed up before, balance function. So balance function again is responsible by the brain, the eyes for the oculomotor activity, content of this control of the motor skill and the posture is by the integrating data storage system with your oculus and modular. Labyrinthine activity, proprioception is by your foot, and the eyes is for the vision, because whatever they capture from the fovea, that gets transmitted to the brain, and based on that the brain says how you have to behave or how you have to walk through that particular place. Now coming to the history taking. Now this history is not आपको चक्कर आया, कितने टाइम का चक्कर आया और हमने फलाना दवा लिख दिया, that's not the case now. So there is change. Okay, so how do you take a history? For taking the history, you need to define the characteristic of vertigo as to what kind of vertigo the patient has. So in the initial slide, I told you 4 things. One is rotatory spinning, imbalance, tilting and swaying, and on the board, rocking. So these are the 4 things that you need to clarify from the patient. What kind of vertigo is it? Clear? Rotatory spinning, imbalance or unsteadiness, tilting and swaying, and rocking over the board. So these are the 4 things you need to understand for the characteristic. Why is it important? Because that will help you define the type of vertigo. If it is rotatory spinning, it will go in the probable of BPPV, benign paroxysmal positional vertigo. If it is more of a tilting or just going on one side, that can be peripheral vestibulopathy, unilateral peripheral vestibulopathy. If it is any kind of imbalance, it can be triple PD, it can be sensory ataxia. Okay, so you need to think about all those lines. Then comes on the board. Now on the board is mainly Marr-Debarkment syndromes. That can be one of the reasons. So that, or it can be triple PD. Very commonly the patient will say, हमको लग रहा है कि हम board के ऊपर घूम रहे हैं. So you need to define what kind of they are getting that giddiness about. Now duration. The duration of the attack should be differentiated by seconds to minutes, minutes to hours, and hours to days. This is how, and constant. Now the 4th point is constant. So when you said second to minutes, minutes to hours, and hours to days. So when you say about seconds to minute, it is more again about BPPV. It can be a TIA also, or it can be a vestibular paroxysmia. If it is minutes to hours, it can land up in Meniere's disease. If it is days, if it is days, yes, if it is days, it's going to be vestibular migraine, and if it is constant, it will be triple PD. Persistent perceptual postural dizziness. So this is how you define and start differentiating in this. Remember one thing, that your history of the drugs should be also identified when you take the history, because in the effect of drug, this history is nullified. So whatever history you take and whatever you are asking the patient should be narrated in 2 episodes, basically minimum 2 episodes. That is the first episode and the current episode, because even a patient with 1 attack of BPPV will have a psychosomatic disorder at the end of the current presentation, because इतना साल निकल चुका है उसके साथ. So, or it may just be an anxiety disorder, because anxiety will precede vertigo at some point of time. So that is one basic understanding. Now ulcerated head movements. Head movements we want to ask because we are thinking about BPPV. Yes, BPPV itself is 14 types and there are 12 maneuvers for the correction. So that will help you to define at what movement you are getting. Now if you are aware of the XYZ, so X में they will say कि जब मैं तकिए पे सर रखती हूँ तो मैं साइड करती हूँ तो मूवमेंट. So now you can understand it's a horizontal canal. They will say कि झुकने के टाइम पे आ रहा है ना, झुकने can be more about anterior canal BPPV. Okay. Posterior canal में they will tell you मेरे आड़ा देख के screen देखते समय I'm feeling giddy. So you understand, so that oblique movement or the Z-axis movement that they are giving, that's a hint. The other possibility is a vestibular paroxysmia where you have this ICA loop over the 7th and the 8th. But then that is available on all the, you see mainly all the MRI reports you will have it. So that is also one diagnosis of exclusion, and the only criteria which Barani says is that you should give carbamazepine. Now that is also one additional thing because Stevens-Johnson syndrome is common with carbamazepine. So you will have to think over before giving that drug. Now my neuro prefers giving divalproex more often in such cases. So that's again a touch and go situation, So that's the criteria. TIA will have 5 Ds and 3 Ns. So transient ischemic attacks will not leave you without any neurological symptoms. It is a neurological case. So you will have a diplopia, you will have a dizziness, you will have a diplopia, you will have a dysarthria, you will have a dysphagia, you will have a drop attack. So there are 5 Ds and 3 Ns, nausea and nystagmus numbness. So this is how you classify such cases. Coming to the ear problems. Now it is very routine for us as an ENT to ask that 5 red flags. We are taught from our post-graduation days. It should be ear discharge, decreased hearing, facial palsy, tinnitus, and the 5th is going to be vertigo. Any collaborative symptom can be a triad of symptoms. For example, in Meniere's you will have a fluctuating hearing loss, sensory neural hearing loss, you will have a tinnitus. So that goes into a triad of Meniere's disease. Patients presenting with ear discharge or someone who is having a long-standing ear infection case can proceed towards a chronic otitis media. So that's again a detailed history. So these things are a very routine in a ENT practice, but this question should be asked. You should not come with a mindset, नहीं इसको middle ear का problem नहीं हो सकता. Many a time it is an unidentified middle ear. That cholesteatoma is lying down in some hidden area that we are also for sinus tympani and Prozac space. You may not be aware it is getting exploded into the mastoid. It may not be even coming anteriorly and going behind posteriorly. You may never know. Covering up your oval windows and round windows and entering your canals, semicircular canals, that can be one of the situations. So you can always think over out of the box, as to what can happen. That may be one of the case, but you should be very open to even understanding that various situation. History of headaches. Now, history of headaches is very commonly that you should be asking because mainly in cases of migraine-induced vertigos or vestibular migraine. So, what kind of headache? It is unilateral, pulsating. That need to be understood. So, that history of headaches is important. Again, intolerance to light and sound is part of the migraine history, and the history of fever and upper respiratory tract infection is in respect to labyrinthitis and vestibular neuritis. So labyrinthitis will also involve your hearing. Vestibular neuritis will escape the cochlea. Okay. Neurological symptom you should always ask. You may never know an acute vestibular syndrome may be a pica stroke, and you are thinking of doing a vestibular evaluation. You are thinking of doing a caloric test, and you realize actually it was the HINTS test that had to be performed in such patients. Because you have just 3 hours or 3 to 6 hours maximum, that golden period, to save the life of the patient. So now you can understand how complex vestibular neuritis is as versus to your stroke. So that, of course, that understanding is important, and everybody should run the HINTS examination, that is head impulse test for nystagmus and skew deviation. So basically head impulse test will be positive in a peripheral vertigo. Test of nystagmus where you will have a unilateral horizontal beating nystagmus to the normal side, and you will have a skew deviation will be negative in a peripheral vertigo. But when it comes to an HINTS positive, or maybe when a head impulse test is negative, again head impulse test negative comes under normalities or central vertigo. Test for nystagmus, any vertical or direction changing nystagmus, they will come under your central vertigo, and skew deviation is one of the, when you do the cover and cover test, one of the eyeballs will shift up, that will come under the central vertigo. These are the signs of particularly of stroke. Gaze evoked nystagmus is always very confusing. You'll have a bilateral, do the gaze 30-degree angulation, you'll get a beating nystagmus on either side, you're confused. You may find it even in migraine cases very commonly, but just keep in mind gaze evoked nystagmus is again coming from the central signs. So don't just leave it like that. It's very important. Comorbidity. Now, history of hypertension, diabetes, TB and asthma. That's a very common thing that used to ask, because that will help you to brief about the medicines that the patient is taking. Also the health condition of the patient, polypharmacy being happening, drugs getting interacted. So that will help you further with the diagnosis. In Bombay, peer pressure, psychological factors, they add on to your mental health conditions also affects your vertigo. The sleep work cycle, if the people are working at the late evening, so naturally they are bound to break the biological rhythm, so they will have this kind of vestibular migraine like symptoms. On current medications, I already told you, current medications you need to ask of the history because to avoid the polypharmacy. History of past hospitalization will tell you that how bad were the vertigos in the past. Some people must have landed up in hospital, they were so bad, there were palpitations, they were sweating, and they landed up. Generally, these cases are the Meniere migraine spectrums who generally land up because they get a very severe attack of vertigo and they have not done a proper prophylactic medication. And history of medicine allergy is very common. We take it for medical legal purposes also. So just a brief about the spectrum of vestibular disorders that I am opening, and this has been taken from Bharani Society, but I have put it in a layman language for an easy understanding of the subject. So vestibular neuritis is basically the inflammation of the vestibular nerve, mainly the superior vestibular nerve is getting affected, and labyrinthitis in the entire involvement along with the cochlea. So you get acute attacks of vertigo, a severe rotatory spinning, you will have imbalance, there will be hearing deficit association mainly in labyrinthitis, And upper respiratory tract infection is one of the causes why you get all this. Meniere's disease, rotatory spinning vertigo, it is minutes to hours. There will be a fluctuating hearing loss. The patient will say, I was getting initially some aura of symptoms or aura of symptoms. Why I am saying? Because it is nowadays Meniere's migraine spectrum. So generally there is something which will happen before the attack that they will feel now it is going to start. And there may be associated tinnitus, may not be associated, but in Meniere's you will definitely have a tinnitus, and there will be nausea and vomiting. The hearing loss in Meniere's disease is mainly a sensorineural hearing loss. Now migraine. Now why I have kept Meniere's disease, vestibular migraine and triple PD in that they are all from the same boat. So basically if you have 20 patients entering your clinic, 18 will be actually migraineurs. There will be 1 or 2 will be classically Meniere's at this point of time. Because as per the research in US, Meniere's disease burns out after 7 years. Okay, so now the patient may actually present with migraine and sensorineural hearing loss, not a classical of the symptoms. So even if you do glycerol test, you will get it negative. Present state, it is already burnt out. So when you do now talking about the vestibular migraine, migraine will be rotatory spinning, it will be hours to day, there will be an associated headache, intolerance to light and sound, blurring of the vision, there will be severe anxiety in this patient, nausea and vomiting, and they may be having associated hearing deficit and tinnitus. So they have tinnitus, it can be because of the abnormalities of the neurotransmitter vertex, and the hearing report will be normal. Unlike in Meniere's where you will have a low frequency hearing loss, in such cases the hearing report will be normal. You can also consider that maybe that attack has passed and now the hearing has come back. In Meniere's disease there is a distal membrane that breaks and the interlymph and perilymph gets they mix with each other. You may consider that, but always start first with migraine prophylaxis rather than entering into the diuretic and the other zones of the drug for the drug management of such cases. Triple PD, very common in our OPDs. Persistent perceptual postural dizziness, very difficult to label such patients as a psychogenic vertigo because the symptoms are very, very unique in such cases. It's very either on one side or that side. So it's difficult where the patient stands together. Now the question arises just like कि पहले अंडा है या मुर्गी, because it is either the vertigo which has come first or the anxiety which has come first. The answer will be that the vertigo has come first, and then the anxiety precedes because patient has got scared with that first attack. That first attack can be anything. It can be BPPV, it can be vestibular neuritis, it can be just be an acute attack of vestibular migraine. But the patient has the potential to land up in such case because of the psychosomatic symptoms that we have and the neuroplasticity of the brain. Okay, so chronic dizziness is non-spinning, it is more of imbalance, it is associated with head movements. It means the differential diagnosis can be BPPV again. One episode of vertigo can give rise to such symptoms. The patient will be having a behavioral disorder. Generally they are perfectionist, they are personality A, they want things in place. And mainly the presentation that I have seen is even the males have this kind of illness, So these are also predominantly males. Migraine is more predominantly females, but triple PD if you see it again in males also. And social phobia, they will fear going to supermarkets, they will fear going to the mall, they will fear for each and everything that they do in their life because they are overthinkers and they are thinking right before that actual situation has happened and they don't know what is the rescue mechanism. And depression, anxiety and migraine are a part of this scenario. So they are all the three that I mentioned are on the same boat. Okay, now talking about the classic BPPV. Now classic BPPV is rotatory spinning, it will be less than 1 minute based on the Bernari Society. There are 14 types, we have 7 from the posterior canal, 5 from the horizontal canal and 2 from the anterior canal. That is how we differentiate. And there is variance in cupular lithiasis and canal lithiasis. It will be associated with head movements, it will be having anxiety, nausea, vomiting, but there will be no hearing deficit. But the first episode of vertigo will be longer and the classic will be while getting up and lying down on the bed. Now geriatric fear of falls. So this patient have generally imbalances, age related, it worsens and darks and they have auxilopsia, means when they are walking there is constant movement of the vestibular apparatus and such cases have sarcopenia also, they have muscle loss, the tonicity of the muscles are lost And that is why the collaborative balance and functions have gone down in such cases. Non-vestibular causes. When I talk about non-vestibular causes, actually I am talking about the cardiogenic causes of vertigo. So it is lightheadedness, like for example presyncope and all, blackouts, change in posture that will be mainly seen in orthostatic hypotension, abnormal heartbeats, which is in the symptom known as POTS. Okay, so there will be tachycardia syndrome when the patient stands. So that's POTS. So apart from otoscope, always keep a habit of having a BP apparatus, pulse oximeter, everything with you, because you may never know which your patient may not be actually coming from the ear and the other, and 128 Hz training for also, because it can be a neurological case also. Central vertigo, fall, loss of consciousness, diplopia, dysarthria, dysphagia, tingling numbness, hemiparesis, the vitals have to be taken. Vestibular paroxysmal, these are acute attacks. As I mentioned, there should be more than 10 attacks as defined by Banari Society, and it should be associated with head movements. Now, general examination of the patient. So, as soon as the patient walks into your clinic, now, you can see how they are walking, the speed at which they are walking, how many people are holding them, and how confident is their walk. That could be easily made out, you know, when they walk towards to sit, just to sit in your front of you at that point of time. So keep a watch on that, you know, it will tell you a lot of things about them, you know, especially their gait. So that will also define. Pallor ictus, cupping, lymphadenopathic edema, these are the common things that we have already learned in our medicine. It's a very rare situation, but again anemia can be one of the leading causes where you have vertigo and you have an hypoxic attack, and you will just mix it with vestibular migraine. So there will be more detailing in the lecture that Dr. Apeksha is also going to take at in the second session. Vitals, as I already mentioned, you may be having a patient who is actually having a fever. There may be an issue with the hypotension, pulse, sugar, hypoglycemic and saturation. So basically sugar is about 250 will also give you head heaviness, sugar below 70 will also give you spins. So these are some metabolic syndrome that you need to understand. It not necessarily it is migraine or it is a syncopal attack. It can be a collaborative effect of something else. In the COVID, when in 2022 there was this Omicron variant, I could maximum see the number of vertigo presenting with neurological symptoms. In fact, there was a paper which also came out that the neurological symptoms have increased post-COVID, you know. So because this is one of the commonest scenario. Till date, I still see CBC where I suspect viral infections, you know, because there can be that partially that immune system is trying to fight it out, not classically going into neuritis, and the patient may be having a pre-existing vestibular apparatus weak. We may not be defining it, but it may persist like that. So don't think that everybody is having a complicated ear syndrome, or just try to differentiate your illness between mild, moderate and severe. So that is how you come to know that where you have to go. ENT examination, without seeing the eardrum, nothing starts for me at least, you know, and even for I believe my ENT colleagues, that we should be thankful that we know how to use an otoscope, because we have more clarity over the eardrum rather than our other colleagues, because they can't go through that and we are easily going to make it out that where is it going, because at least 20% of the headache is gone that is not involving the middle ear. And then starts our tuning fork test that further adds to our diagnosis. So at least you should know if the TM is normal or there is a perforation. So that is also fair enough. Okay, we have reached there. Because even we sometimes make to differentiate if there is something in the attic which is happening, and we take help of HRCT to clarify attic area of the or the epitymphanic area. So at least you doing the tuning fork test helps you to at least rule out whether it is going to be conductive, sensorineural or mixed hearing loss. So the other diagnosis that we were thinking about is already gone. Neuro-otological examination includes Romberg's, Unterberger's, head impulse test for nystagmus Q, that is the hints, then Romberg's, Unterberger and the positional test that we need to do. Further available modalities, we have a pure tone odometer. Now, pure tone odometer is a basic thing, it's like a CBC for us. We start with that, you know. So that is helpful. If we are suspecting anything coming from the middle ear, we add on to an impedance, which will have a tympanometry and stapedial reflex. We further have a VNG. But if you are very strong in your bedside clinics, now you will not require a VNG in your hand, because that's an added, investment of 10 lakh rupees, where you will have to further proceed. So VNG will have n number of tests that you can perform. MRI brain with internal auditory meatus, the commonest that we perform in a vertigo protocol, and HRCT temporal bone if you want to confirm if there is no perilimb fistula or the superior semicircular canal dehiscence, that is the third window syndromes. The commonest investigation, just to enlist quickly, is CBC, urine routine, electrolytes, glucose, HbA1c, thyroids, ANA blot, vitamin D, B12 and ECG. So we will be talking more about it as we proceed in the session. And the management is very simple. Management is that you should be very open to discussion with the patient, keep them aware about your situation, about their symptoms. More the awareness they have, the more the less scared they will be about the attack of vertigo. Medicines are there for the symptomatic relief. You can also add to benzodiazepines. Canalic repositioning maneuver is the gold standard treatment for BPPV. Vestibular rehabilitation will help in the conditions of vestibulopathy or where there is an vestibular hypofunctioning, and monitoring and follow-up will help you to know that you have not gone wrong in your diagnosis. Okay? And the final conclusion for my session is a clinical evaluation is must. You should be able to rule out central vertigo. Medicines are adjuvant and rehab is the main for the peripheral vertigo. So, thank you. I'm open. And because of this, now the recent advancement in treatment is virtual reality. With that Oculus, these people are trying to figure out if we can have an artificial intelligence which can help so that they come out and meet the public. Sometimes we also have to use cognitive behavioral therapy or counseling sessions, to get the fear out of the patient, because more of the time, half the time they are scared. And a drug of choice is generally an SSRI or SNRI or a TCA that we add on with the rehab for at least 8 to 12 weeks. People say triple PD doesn't get cure, I am not of that opinion. Okay? Any more questions? Okay, so we proceed to the next session.
Beneath Desai, let me give you a brief introduction of Dr. Desai. She is the founder of Swar Voice Clinic in Borivali, Mumbai, specializing in voice and swallowing disorders. And she is also the owner of Desai Orthopedic and ENT Clinic. She is MS ENT from GMC Nagpur. She has a fellowship in laryngology and CO2 laser surgery under Dr. Nupur Nerulkar from Bombay Hospital. She has also got an international fellowship in laryngology under Professor Mark Rimakel of Luxembourg and Dr. Kishore Sandhu of Switzerland. She is also proficient in phonosurgery, office-based laryngology procedures, laser surgery, swallowing rehabilitation, which is phagosurgery. She is a winner of the Raj Hercule Award in 2013. She has co-authored multiple publications, and she is invited faculty at national and state laryngology conferences. So, okay.
The same 21st June.
Yeah. 1 second.
You want to present next? Non-total energy is only
to deliver this talk, and your lecture was as always excellent. So my job here is to talk about vertigo as a complication, mainly in cases of middle ear conditions. So I am an ENT surgeon, and I would be delving more into middle ear causes of vertigo. So again, this is a picture thanks to Dhingra. Here, just in brief about middle ear anatomy. So the middle ear is mainly situated between the outer ear and the inner ear. So why middle ear is important and how it can give rise to vertigo. So the external limit is the tympanic membrane. Tympanic membrane is connected to the inner ear via the ossicles. So anything impairing tympanic membrane ossicular mobility, it can give rise to vertigo. It is connected to the nasopharynx via the eustachian tube. So middle ear is also going to give rise to vertigo if there are certain situations, conditions affecting the eustachian tube or the nasopharynx. And again, the inner ear or the otic capsule we know is the strongest bone of our body, but it is dehiscent at the round window and the oval window. So again, they are connected to the middle ear. So the diseases in the middle ear are going to affect the inner ear via the oval window and the round window. So moving ahead, these are the causes in brief. There could be trauma, there could be perilymphatic fistula, acute suppurative otitis media with effusion, chronic suppurative otitis media, chronic suppurative otitis media with cholesteatoma, otosclerosis, barotrauma, and eustachian tube dysfunction. So we would be discussing each of these causes in detail. So trauma. We see head injuries quite commonly, and vertigo and dizziness could happen after head injury. So the most common causes is again benign paroxysmal position vertigo. Further ahead, there could be labyrinthine concussion. There could be a traumatic tympanic membrane injury with ossicular injury. There could be a perilymph fistula following the trauma. There could be a complete unilateral vestibular loss. There could be trauma to the endolymphatic, it could be endolymphatic hydrops following the trauma, or there could be a utricle or saccular injury. So because benign paroxysmal positional vertigo is the most common cause following the trauma, that should always be kept in mind. The cause of it is mainly when the head trauma gives rise to traumatic dislodgement of the otoconia from the macula of the utricle. So the forces applied to the skull during the trauma can cause traumatic dislodgement of otoconia from the macula of the utricle. Again, the recurrence rate of the post-traumatic BPPV is similar to the idiopathic BPPV, but it would require more positioning maneuvers to achieve success, unlike BPPV wherein almost 85 to 90% times first maneuver is successful. And the other thing is, the differentiating factor is BPPV following trauma is going to affect both the ears almost in 25% cases as compared to idiopathic, which affects bilaterally only 2% cases. Labyrinthine concussion is mainly a non-specific injury to the membranous labyrinth from the acceleration and deceleration forces on the bony labyrinth following the trauma. So the trauma is going to give rise to the forces on the bony labyrinth, which is going to pass on to the membranous labyrinth. And this trauma can give rise to rupture, bleeding or ischemia within the membranous labyrinth, giving rise to vertigo. A unilateral vestibular loss, basically it can occur after a head trauma even when there is no temporal bone fracture, and this would not have a hearing loss. So there is a complete vestibular loss wherein there is imbalance but there is no hearing loss. And for the causes of this are mainly traction or injury, induced demyelination of the vestibulocochlear nerve, or trauma which gives rise to a bleeding or ischemia to the membranous labyrinth. So temporal bone fracture, which also is a very common situation that we see, it can give rise to vestibular loss and vertigo. So there are two types of temporal bone fractures. This is more for our ENT colleagues. Mainly the longitudinal fracture, which would be along the axis of the otic capsule, and the transverse fracture, which is going to be bisecting or crossing the otic capsule. So the longitudinal fracture fortunately is more common, and there could be a trauma over the parietal or temporal bone. So the fracture line is going to go like this, and this is going to cause more of a middle ear injury, and fortunately it is going to less likely damage the facial or the vestibulocochlear nerve, and thus vertigo is less common. Transverse fracture is a fracture wherein there is a frontal ortho-occipital injury, trauma on this direction, so it's going to bisect the otic capsule, and there is more likely of injury to the inner ear, and again thus there is more chance of transecting the facial or the vestibulocochlear nerve. Isolated utricular-saccular injury is not very common, but the patient would complain of a dizziness following the trauma, and there would not be any nystagmus. It's a challenging situation, and it's most likely diagnosed by the VEN. And the management, again, it takes a lot of time for the vestibular rehabilitation, and it may take months for it to recover. Traumatic ossicular injury. So if there is an injury to the eardrum, that can be transmitted to the ossicles, and this can happen like we discussed along the longitudinal fracture. The fracture coming from the parietal lobe or a temporal lobe. So it will go like this, and it will damage the eardrum and the ossicles. And in these cases, when there is a stapes injury suspected, that is going to cause more of a sensory neural hearing loss or vertigo, because like we know, stapes is connected to the inner ear through the oval window. Now, a perilymphatic fistula. So what is a perilymphatic fistula? Basically, there is a small tear or a hole in the membranes that are separating our air-filled middle ear to the fluid-filled inner ear, and thus the inner ear fluid, which is the perilymph, is going to leak into the middle ear through the leak. So the causes of it are mainly barotrauma from the scuba diving or blast, wherein there is a sudden increased external pressure outside. There could be heavy straining following severe bouts of coughing, weight lifting, or even after childbirth, when there is severe straining, following a head trauma, or it could be iatrogenic, that is after certain surgeries. There could be a small leak at the level of the membranes, wherein the fluid in the perilymph is going to leak into the middle ear. So the presentation of the complaint patient is usually there is a unilateral hearing loss, which is most likely sensory neural. If there is a perforation in the eardrum, the patient would complain that there is blood or fluid coming out of the ear. There would be tinnitus and perforated eardrum. There could be vertigo or unsteadiness. It is a very notoriously difficult condition to diagnose. We might require a case, we might have to do radiological investigation, wherein a CT scan would help us to identify the site of leak. The treatment, if it is a small leak, it is most likely conservative, wherein the patient is advised to take bed rest for some time. If it doesn't seal on its own, if the leak doesn't seal on its own, then a surgery is warranted, wherein we do an exploratory tympanotomy and we seal it with the help of a fascia or a graft. Acute suppurative otitis media, which is one of the most common conditions we see in our OPD. And this giving rise to vertigo, present situation, it's very rare, fortunately, to the early diagnosis by the doctors. We have very good antibiotics, and there is very good awareness amongst the healthcare professionals. So acute suppurative otitis media leading to vertigo is now a very rare situation. Now the causes are mainly if there is labyrinthine irritation because of the bacterial toxins or mediators in serous type, and the bacteria can directly enter into the inner ear via the oval window or round window, and both are causes giving rise to vertigo. Now in these situations, the patient would have more of an audiovestibular damage if the patient keeps getting it repeatedly. Now there is a study that if a child is having more than 8 episodes in the childhood of recurrent acute suppurative otitis media, then he will have a long-term effect on the balance and vestibular function. So audiogram is going to show more of a conductive loss. MRI will also show more of enhancement at the basal labyrinth. The treatment is mainly myringotomy, wherein we have to make a small hole over the eardrum in the anterior inferior quadrant, and we have to drain the fluid so that the pressure is immediately released, and treat the patients with antibiotics and steroids. So serous, this can give rise to, basically if untreated, then initially it is serous labyrinthitis, then that will get infected wherein it is purulent labyrinthitis, and if untreated, then these patients, it can complicate as meningitis, because we all know that the endolymph is connected to the CSF. So we have to treat this case very early. Again, otitis media with effusion is very similar pathophysiology as acute suppurative otitis media. The treatment is mainly a myringotomy, wherein we have to make a perforation in the anterior inferior quadrant and drain the fluid as early as possible, and treat the patients with antibiotics and steroids. So this is a very easily treatable condition, and the complications can be easily managed and controlled if we treat the kid on time. So chronic suppurative otitis media, we know can present with intratemporal complications such as labyrinthine fistula, mastoiditis, peripheral facial nerve palsy or labyrinthitis, and fortunately, labyrinthitis amongst these is the least common complications. The symptoms, if the patient has labyrinthitis, could be, there could be hyperefusis, there could be vertigo, tinnitus. If we might have a mixed to moderately, mild to moderately mixed hearing loss, because obviously it has gone into the inner ear. We need a CT scan to identify where is the site of injury. We need to identify that where is the level of fistula, over whether it is at the level of basal turn or it is at the lateral semicircular canal level, and the patient has to be posted for surgery as early as possible so that we can settle the patient. Now, cholesteatoma. We all know what a cholesteatoma is. It's basically a gradually expansile epithelial lesion in the temporal bone, and it is aggressive disease and it can result in erosion of the surrounding structures. So chronic suppurative otitis media with cholesteatoma has to be treated with surgery. Typically, the cholesteatoma is located in the posterior epitympanic space, or it can be involving both the pars tensa and the flaccida. So these conditions, the disease is more aggressive and more likely to damage either the basal turn or the lateral semicircular canal, because we know cholesteatoma is locally aggressive. So once the patient complains of vertigo and the patient has a cholesteatoma, the surgery is urgently warranted. So this classification is more for the ENT colleagues. Intraoperatively, depending upon the location and the erosion of the cholesteatoma, Dornhofer and Milewski has divided it, classified it into 3 types. The first type, so in the picture A, the yellow one is the bony labyrinth, the blue one is the perilymph, and the light blue one inside is the endolymph. So if the disease in first stage is basically the cholesteatoma has damaged the bony labyrinth, but the perilymph and the endolymph is intact. So this is a safe disease, and here clinically, intraoperatively, we would be able to see the blue lining of the perilymph. In stage 2, the cholesteatoma has eroded the perilymph, and in stage 3, the cholesteatoma has eroded the bony, the peri, endolymph, and gone into the organs. So these are these are the tricks and tricks for the surgery in these cases. The first step is basically we have to finish the entire disease clearance in the first initially, and then move on to the clearing the disease at the level of the semicircular canal. So mastoidectomy, you clear the disease from the mastoid part, you do the middle ear part, you do finish completely, and then address the lateral semicircular canal fistula. Move on to higher magnification. Like we discussed the first and the second stage, herein you can try by removing the matrix of the cholesteatoma gradually. The epithelium, if you cannot find a clear cleavage between the matrix and the membrane, then you may have to leave the membrane behind, because while removing it, there is a risk of giving rise to complete sensory neural loss to the patient. So initially, gradually try removing the keratin and debris, and firstly you try to remove the matrix. If you cannot remove the matrix, just leave it behind, and if once you have removed the matrix, then you have to reconstruct it with the temporalis fascia or the bony patty. Again, post-surgery, the vestibular symptoms will take some time for recovering. The hearing symptoms may not recover. Otosclerosis, this is more for the ENT colleagues. So, what we need to know basically is otosclerosis, about 30% of patients would complain of vestibular symptoms. The vertigo can be before the treatment, during the treatment, or after the treatment. And it could be an immediate complication of the surgery or delayed complication of the surgery. So otosclerosis is the fixation of the foot plate of the stapes. So for normal mobility, the eardrum is connected to the inner ear and the oscular chain has to be mobile completely. But there is calcium deposition at the level of the foot plate of the stapes, and thus the foot plate gets fixed, and thus it gives rise to hearing loss and vertigo. So there are a lot of huge pathophysiology of vertigo, why it happens in otosclerosis. Mainly, there could be the degeneration of the vestibular nerve, there could be the degeneration of the ganglion of the vestibular nerve, that is the Scarpa's ganglion. Otosclerosis level at the cochlear endolymph will give rise to certain level of atrophy and hyalinization of the spiral ligament. There could be further damage to the spiral ligament, which is going to disrupt the chemical balance in the endolymph, and for giving rise to biochemical changes in the membranous labyrinth and vertigo. So this is very important slide. Pre-surgery, pre-operatively, the causes of vertigo. So there could be an associated endolymphatic hydrops, there could be detachment of the otoconia, vestibular end organ neurodegeneration, or certain enzymes or cytokines which give rise to vertigo. So the incidence is around 8.6 to 30%, and usually if the patient has a vertigo before the surgery. It could be either fluctuating or permanent, okay? And the treatment is mainly medical line of treatment. Intraoperatively, there is a chance of giving rise to vertigo almost 2% of the times. So you have to counsel the patient that there is a possibility before the surgery that the patient might develop vertigo. And the causes would be if you have, there would have been a lot of manipulation of the foot plate, or you have done a lot of suctioning at the level of the oval or at the level of ossicles, and there could be an intraoperative floating foot plate. Usually intraoperative vertigo, if the patient has developed, it is temporary and it settles with bed rest or medications. Now immediately post-operatively, the patient could have vertigo and the incidence is relatively higher, about 3 to 70%, okay? That could be because of a serous or chemical labyrinthitis. There could be a lot of suctioning at the perilimb which can give rise to it. There could be penetration of an instrument or prosthesis at the level of the vestibule. There could be trauma of the utricle or saccule. There could be again release of proteolytic enzymes, antigen antibody reaction because of the piston. There could be change in the pressure of the labyrinthine fluid, or there could be a reduction of the blood supply to the labyrinth. Now this is a very critical situation because the patient doesn't have vertigo before the surgery and the patient has developed the vertigo after a few days after the surgery. So usually again you have to do a lot of counseling to the patient and it is temporary, it is going to eventually settle down. But if you know that there are certain causes which can be corrected, so these patients, if there is a particular cause which we would discuss later, then you may have to take the patient again for surgery and settle it. And late post-operative, after many weeks if the patient is having a vertigo, the incidence is around 0.5 to 17%. There could be certain complications which has happened. So the patient might have a perilimb fistula, or there could be a secondary endolymphatic hydrops. There could be irritation of a prolonged foot plate, prolonged prosthesis. So prosthesis that you have introduced that could be a little longer, that can give rise to the vertigo. There could be a granuloma forming at the site of the surgery. There could be certain bony fragments into the vestibule irritating the labyrinth and giving rise to vertigo, or there could be a iatrogenic air or pneumolabyrinth or air from the medial layer that has gone into the inner ear. That is a barotrauma. And usually in these cases either the vertigo can be temporary, it could be fluctuating, or it could be permanent. So medical line of treatment, firstly if there is a cause, like we know if the patient is having suppose a prolonged prosthesis, then the patient we have to immediately take the patient up for surgery. If there is an iatrogenic perilimb fistula, then we have to take the patient up for surgery. And if there are certain other causes where we have to counsel the patient and it may take a lot of time, obviously medical line of management and vestibular rehabilitation exercises. So perilimb fistula, like it can happen after stapes surgery, and it is a rare complications fortunately, but 1/3 of the surgical revisions happen because of the perilimb fistula. So immediately post-operatively the hole has not been adequately sealed with the graft. Thus the prosthesis moves and it causes increased pressure during coughing, sneezing or strong laugh also. So what has happened typically is that in the surgery, you make a hole over the stapes foot plate and you seal it with the graft and you put a Teflon piston. But the seal is not adequate. The seal has not been adequate, and thus because of the increased pressure in the middle ear that happens during strong bouts of coughing, sneezing or strong laughing, the patient is experiencing vertigo. And again with this, the patient is going to experience fluctuating hearing loss. You have to see the patient, you have to do an audiogram, and the hearing is deteriorating gradually, so there is declining cochlear function. And these cases you have to urgently explore and seal it as early as possible, because with this you are not only introducing the hearing, you are actually giving rise to vertigo and hearing loss, blood. There could be infection also which could be going into the inner ear. So again, now the incidence can be reduced if you have recently that the best thing that we put basically is the vein graft, and the vein graft is excellent for preventing these kind of perilimb fistula. There are other things we can use, a fascia, fat or gel foam, but presently the vein graft is the best thing. And like I said, this needs urgent exploration because there could be risk of meningitis or permanent hearing loss. Prosthesis, if you have put it, during the surgery you put a prosthesis, the length of the prosthesis going into the vestibule should be 0.5 mm. If it is longer, so here on the scan we can see that the length of the piston that you have introduced is around 1.7 mm, which is very long. This is going to give rise to vertigo. And again, this vertigo worsens with head position, Valsalva, strong pressure during coughing or strong laugh. And this, you have to do a scan. Once you identify that this is the cause, you have to urgently take the patient up and reduce the size. So, reparative granuloma is very common after staphytectomy. So, staphytectomy was done previously where we would remove the entire stapes. Now, what we do is over the foot plate we are making a hole. So, after the removal of the complete stapes, previously there would be a lot of granuloma formation, and that would present as a hearing loss or vertigo. And typically, the presentation would be within 5 to 7 days after surgery, and the treatment fortunately is conservative and a lot of counseling to the patient. Barotrauma. Now, this is a very interesting condition that we are seeing because lots of people are doing more and more of scuba diving nowadays. So, with scuba diving, a lot of air travel, we are seeing a lot of barotrauma cases. So, typically, the pathophysiology is interesting. So, barotrauma is going to cause two types of effect. Either it could be transient or temporary, and it would resolve within less than a minute, and it is a benign situation, or it could be persistent, lasting for a longer duration and more than 1 minute or hours, and it is more serious. So just in general about the pathophysiology. So when during a scuba diving, a patient is descending, the person is descending down, what we need to understand is the external pressure is increasing, and we have to maintain a certain pressure in the middle ear. So the eustachian tube, what it is going to do, because the descent is very fast, the eustachian tube will completely close down, and there is going to be a lot of negative pressure in the middle ear. So a lot of negative pressure in the middle ear, what would happen is the blood vessels along the ossicles, along the tympanic membrane, they are going to drain the fluid and blood into the middle ear. So this is the picture that you would typically see over the eardrum. This is a normal eardrum, upper one and the lower one. Lot of congestion, inflammation, and the fluid, serous fluid would get into the middle ear. And so patient is now, once he has gone down, the patient has been unable to maintain the middle ear pressure because he doesn't know how to use the eustachian tube, or the descent has been very fast. Then the patient is going to have a fast ascent because he is not comfortable in the ear. He is going to experience pain, fullness. Then he is going to go up quickly. So what would happen is, again, the external pressure is increasing, but our eustachian tube is totally collapsed, and the pressure in the middle ear is going to further increase. So all of that fluid is going to get collected into the middle ear. So once the patient comes up, he is going to experience severe pain, hearing loss, and at times vertigo. So this is actually a temporary situation. What would happen is, if the patient is having this for more than a minute, and it is a serious situation because this middle ear pressure is going to go into the inner ear via the oval window and the round window. Pressure changes would be affecting the perilymph, and there is going to be a trauma, barotrauma to the inner ear. A lot of pressure and electrolyte imbalances into the inner ear, and there could be fluid and air formation into the inner ear, and that is called as a vestibular decompression sickness. And this air and fluid is going to go into the arterial circulation. It could also go into the middle ear because, like we know, the endolymph is connected to the CSF, and it could give rise to meningitis. So this air and fluid going into the arterial system can give rise to arterial gas embolism because it can go into the lungs and again into the vestibular system, that is called as vestibular decompression sickness. So these two conditions are a medical emergency, and we should be very aware about this situation. So history taking is very important. You have to clinically examine the patient, whether the patient is stable or patient is having breathlessness. That can happen if there is an arterial gas embolism. So vestibular decompression sickness or arterial gas embolism will be associated, might be associated with neurological manifestations, like because that can go into the brain and cause meningitis along with vertigo. So if it is an emergency, like in vestibular decompression sickness or arterial gas embolism, then we have to give the patient hyperbaric oxygen therapy, and it is an urgent situation that needs to be corrected. For other situations, you have to give the patient medical line of treatment and autoinflation or equalization exercises. So again, prevention is always better than cure. And if any person is suffering from upper respiratory tract infection or is having a lot of decongestion usage or eustachian tube anomalies, these patients should refrain from doing scuba activities so that he doesn't land up into these complications. And our eustachian tube dysfunction is a very common condition that we see in our OPD. So what is the eustachian tube dysfunction? Is mainly there is a failure of the functional valve of the eustachian tube to open or close properly. So what would happen is, like we discussed, there's a lot of negative pressure in the middle ear created. The tympanic membrane is going to retract, the stapes is going to push against the oval window, and that will stimulate the perilymph. The patient is going to complain with a unilateral or acute episode of vertigo, nausea, vomiting, even gait imbalance, or the patient may have a sudden fall. And chronically, the patient will experience it more on rapid movement because there is a rehabilitation or compensation that has happened from the other side. So the patient will not experience it on routine movement, but if there is a sudden movement, in chronic situations, patients will experience it. And if the patient is having bilateral eustachian tube dysfunction, then he is going to experience more of a vestibular dysfunction and not a vertigo. So the treatment is mainly that you have to identify what is the cause of eustachian tube dysfunction and treat that. It could be allergies, it could be adenoids. You have to treat the eustachian tube dysfunction cause primarily, and you have to give the patient autoinflation exercises. If there is a lot of fluid or collected serous fluid in the middle ear, you drain it by doing a myringotomy. Again, eustachian tube dysfunction can be corrected with balloon dilatation and vestibular rehabilitation. So my take-home message is that middle ear causes are rare, but they form a very important cause for vertigo. Clinical history and examinations are vital, and radiological investigations help in certain situations. All the family physicians must be aware that what is an emergency and when the patient has to be immediately referred, and the emergencies must be known, and certain emergencies do require urgent admissions, and a lot of reassurances is required when the conditions become chronic. So thank you for your valuable time. And this is a wonderful place called as Landor, higher up near Mussoorie, where I had recently been, and I would recommend everyone who is a nature lover to be there, because the science, luckily it's not as crowded and not commercialized and less of people. So it's good for people who are staying in Bombay. We are used to so much of a crowd. So this is a good transition or good change for us. Thank you, Dr. Neha, once again. Vertigo, the incidence is around 0.5 to 17%. There could be certain complications which has happened. So the patient might have a perilymph fistula, or there could be a secondary endolymphatic hydrops. There could be irritation of a prolonged foot plate. Prolonged prosthesis. So prosthesis that you have introduced that could be a little longer, that can give rise to the vertigo. There could be a granuloma forming at the site of the surgery. There could be certain bony fragments into the vestibule irritating the labyrinth and giving rise to vertigo. Or there could be a iatrogenic air or pneumolabyrinth or air from the medial ear that has gone into the inner ear. That is a barotrauma. And usually in these cases, either the vertigo can be temporary, it could be fluctuating, or it could be permanent. So medical line of treatment, firstly, if there is a cause, like we know, if the patient is having, suppose, a prolonged prosthesis, then the patient we have to immediately take the patient up for surgery. If there is an iatrogenic perilymph fistula, then we have to take the patient up for surgery. And if there are certain other causes where we have to counsel the patient and it may take a lot of time, obviously medical line of management and vestibular rehabilitation exercises. So perilymph fistula, like it can happen after stapes surgery, and it is a rare complication fortunately, but 1/3 of the surgical revisions happen because of the perilymph fistula. So immediately post-operatively, the hole has not been adequately sealed with the graft. Thus the prosthesis moves and it causes increased pressure during coughing, sneezing, or strong laugh also. So what has happened typically is that in the surgery, you make a hole over the stapes foot plate and you seal it with the graft and you put a Teflon piston. But the seal is not adequate. The seal has not been adequate, and thus because of the increased pressure in the middle ear that happens during strong bouts of coughing, sneezing, or strong laughing, the patient is experiencing vertigo. And again with this, the patient is going to experience fluctuating hearing loss. You have to see the patient, you have to do an audiogram, and the hearing is deteriorating gradually, so there is declining cochlear function. And these cases you have to urgently explore and seal it as early as possible, because with this you are not only introducing the hearing, you are actually giving rise to vertigo and hearing loss, blood. There could be infection also which could be going into the inner ear. So again, Now the incidence can be reduced if you have recently that the best thing that we put basically is the vein graft, and the vein graft is excellent for preventing these kind of belly fistula. There are other things we can use, a fascia, fat or gel foam, but presently the vein graft is the best thing. And like I said, this needs urgent exploration because there could be risk of meningitis or permanent hearing loss. Prosthesis, if you have put it, during the surgery you put a prosthesis, the length of the prosthesis going into the vestibule should be 0.5 mm. If it is longer, so here on the scan we can see that the length of the piston that you have introduced is around 1.7 mm, which is very long. This is going to give rise to vertigo, and again this vertigo worsens with head position, Valsalva, strong pressure during coughing or strong laugh, and this you have to do a scan. Once you identify that this is the cause, you have to urgently take the patient up and reduce the size. So reparative granuloma is very common after staphytectomy. So staphytectomy was done previously where we would remove the entire stapes. Now what we do is over the foot plate we are making a hole. So after the removal of the complete stapes, previously there would be a lot of granuloma formation, and that would present as a hearing loss or vertigo, and typically the presentation would be within 5 to 7 days after surgery, and the treatment fortunately is conservative and a lot of counseling to the patient. Barotrauma. Now this is a very interesting condition that we are seeing because lots of people are doing more and more of scuba diving nowadays. So with scuba diving, a lot of air travel, we are seeing a lot of barotrauma cases. So typically the pathophysiology is interesting. So barotrauma is going to cause two types of effect. Either it could be transient or temporary, and it would resolve within less than a minute, and it is a benign situation, or it could be persistent, lasting for a longer duration and more than 1 minute or hours, and it is more serious. So just in general about the pathophysiology. So when during a scuba diving, a patient is descending, the person is descending down, what we need to understand is the external pressure is increasing, and we have to maintain a certain pressure in the middle ear. So the eustachian tube, what it is going to do, because the descent is very fast, the eustachian tube will completely close down, and there is going to be a lot of negative pressure in the middle ear. So a lot of negative pressure in the middle ear, what would happen is the blood vessels along the ossicles, along the tympanic membrane, they are going to drain the fluid and blood into the middle ear. So this is the picture that you would typically see over the eardrum. This is a normal eardrum, upper one and the lower one. Lot of congestion, inflammation, and the fluid, serous fluid would get into the middle ear. And so patient is now, once he has gone down, the patient has been unable to maintain the middle ear pressure because he doesn't know how to use the eustachian tube, or the descent has been very fast. Then the patient is going to have a fast ascent because he is not comfortable in the ear. He is going to experience pain, fullness. Then he is going to go up quickly. So what would happen is, again, the external pressure is increasing, but our eustachian tube is totally collapsed, and the pressure in the middle ear is going to further increase. So all of that fluid is going to get collected into the middle ear. So once the patient comes up, he is going to experience severe pain, hearing loss, and at times vertigo. So this is actually a temporary situation. What would happen is, if the patient is having this for more than a minute, and it is a serious situation because this middle ear pressure is going to go into the inner ear via the oval window and the round window. Pressure changes would be affecting the perilymph, and there is going to be a trauma, barotrauma to the inner ear. A lot of pressure and electrolyte imbalances into the inner ear, and there could be fluid and air formation into the inner ear, and that is called as a vestibular decompression sickness. And this air and fluid is going to go into the arterial circulation. It could also go into the middle ear because, like we know, the endolymph is connected to the CSF, and it could give rise to meningitis. So this air and fluid going into the arterial system can give rise to arterial gas embolism because it can go into the lungs and again into the vestibular system, that is called as vestibular decompression sickness. So these two conditions are a medical emergency, and we should be very aware about this situation. So history taking is very important. You have to clinically examine the patient, whether the patient is stable or patient is having breathlessness. That can happen if there is an arterial gas embolism. So vestibular decompression sickness or arterial gas embolism will be associated, might be associated with neurological manifestations, like because that can go into the brain and cause meningitis along with vertigo. So if it is an emergency like in vestibular decompression sickness or arterial gas embolism, then we have to give the patient hyperbaric oxygen therapy, and it is an urgent situation that needs to be corrected. For other situations, you have to give the patient medical line of treatment and autoinflation or equalization exercises. So again, prevention is always better than cure, and if any person is suffering from upper respiratory tract infection or is having a lot of decongestion usage or eustachian tube anomalies, these patients should refrain from doing scuba activities so that he doesn't land up into these complications. And our eustachian tube dysfunction is a very common condition that we see in our OPD. So what is the eustachian tube dysfunction? Is mainly there is a failure of the functional valve of the eustachian tube to open or close properly. So what would happen is, like we discussed, there's a lot of negative pressure in the middle ear created. The tympanic membrane is going to retract, the stapes is going to push against the oval window, and that will stimulate the perilymph. The patient is going to complain with a unilateral or acute episode of vertigo, nausea, vomiting, even gait imbalance, or the patient may have a sudden fall. And chronically, the patient will experience it more on rapid movement because there is a rehabilitation or compensation that has happened from the other side. So the patient will not experience it on routine movement, but if there is a sudden movement in chronic situations, patients will experience it. And if the patient is having bilateral eustachian tube dysfunction, then he is going to experience more of a vestibular dysfunction and not a vertigo. So the treatment is mainly that you have to identify what is the cause of eustachian tube dysfunction and treat that. It could be allergies, it could be adenoids. You have to treat the eustachian tube dysfunction cause primarily, and you have to give the patient autoinflation exercises. If there is a lot of fluid or collected serous fluid in the middle ear, you drain it by doing a myringotomy. Again, eustachian tube dysfunction can be corrected with balloon dilatation and vestibular rehabilitation. So my take-home message is that middle ear causes are rare, but they form a very important cause for vertigo. Clinical history and examinations are vital, and radiological investigations help in certain situations. All the family physicians must be aware that what is an emergency and when the patient has to be immediately referred, and the emergencies must be known, and certain emergencies do require urgent admissions, and a lot of reassurances is required when the conditions become chronic. So thank you for your valuable time. This is a wonderful place called as Landor, higher up near Mussoorie, where I had recently been, and I would recommend everyone who is a nature lover to be there, because the science, luckily it's not as crowded and not commercialized and less of people. So it's good for people who are staying in Bombay. We are used to so much of a crowd. So this is a good transition or good change for us. Thank you, Dr. Neha, once again. Same. So basically the barotrauma, it is the effect in the middle ear and going into the inner ear. Yeah. So basically, typically seen in patients who are doing a lot of scuba diving, and nowadays we know a lot of people are doing it. So what is happening is when you are going down quickly, the pressure, external pressure is becoming more and more positive, and the middle ear has to maintain a certain pressure. If the eustachian tube dysfunction is there, or if the patient has done a very rapid descent, the eustachian tube is unable to maintain the pressure in the middle ear, so it's going to close suddenly, and the pressure in the middle ear is going to become more and more negative. Okay, so then what would happen is the blood vessels in the middle ear, because there is negative pressure around them, that is going to suck all the fluid and blood in the middle ear. So middle ear would be filled with blood and serous fluid, and the patient would experience sudden pain and discomfort, and at times vertigo if it is very fast, because that is connected to the inner ear via the membranous spaces like round window and oval window. Again with this situation, the patient is uncomfortable, so he is going to go up, वापस ऊपर फटक से आ जाएगा. So in that the pressure externally is becoming negative. Eustachian tube is collapsed. The pressure in the middle ear is going to become positive. So again more and more of pain and discomfort in the ear. So the descent has to be rapid, slow, and ascent has to be even slower. The patient should be learned how to do the eustachian tube maneuvers so that the pressures external don't affect the middle ear.
And patients with acute cold.
If the patient has a severe bout of cold, then the patient should be treated with antibiotics, decongestant, topical decongestant. Patient should be taught Valsalva exercises so that the eustachian tube is properly functioning. Otherwise, the patient would complain of ear pain and the infection can go into the ear.
Canal. And when that gets stimulated with the wax, or because of it may have the potential to form a keratosis obturans, which gives a conductive hearing
Yes.
loss in such cases. So they have the potential to scrap the epithelial linings, and that can give rise to, that's quite a detailing, which we are quite aware because it's our daily practice. But basically wax is of the external ear. There is a differentiation of the middle ear is only responsible for sound conducting mechanism. Inner ear is responsible only for the mechanics of the sensory neuron and vertigo. There is an itchy ear, and that is how you get the itchy ear syndrome.
These patients have lot of seborrheic dermatitis also.
Correct, but that's coming from the scalp, which is going inside the ear. So that's the symptom, itchy ear syndrome. They will land up constantly in the candida. So you have to treat the hair scalp. Thank you for being a part. I'm sorry for the mic extremely, but that's a part of the process. And we thank her for an exceptional lecture once again, and coming up for my program at AIB India. And we look forward to many more. Yeah. So she has.
So we understand that the patients have normal scans, the mechanism-based diagnosis to target rehabilitation and a complete functional recovery. Why? Now we'll wonder, why does this topic matter? What is functional vertigo? So functional vertigo is a common, often disabling and misdiagnosed symptom. Dizziness and vertigo are most common reasons for outpatient as well as emergency consultation. Functional dizziness can often lead to repeated investigations, multiple specialist visits. They often get a lot of reassurance, but it does not help. There's persistent disability despite the normal scans. The clinical impact of it is reduced mobility, there's avoidance behavior, the patients start avoiding things, there's workplace impairment, and there's increased health anxiety and caregiver burden. So we all know of patients like this, we call them as the fat file patients. So they usually, the patients have a lot of files, they have multiple ENT visits, they have a normal MRI scan, they have inconclusive lab reports, and a lot of reassurance which is unhelpful. Usually we see around 50% of persons who present to clinics for dizziness, they have a psychological component. Yet multiple investigations fail to capture the reality of their distress. The reality includes the reduced mobility, severe avoidance behavior, their health anxiety and persistent daily disability. What are abnormalities? Disorders like diabetes, arthritis and some psychomotor agitation or retardation. What are the characteristics of psychogenic dizziness? So usually it is a continuous dizziness present for long periods of time. They are younger patients, predominantly females. There's also associated symptoms of panic attacks like headaches, breathlessness, nausea, sleep disturbances, anxiety, palpitations. The symptoms are aggravated due to stressful life events. There's a normal neurological bedside examination. They can also reproduce the symptoms accurately when asked to do so. The most important entity here is the triple PD. So what is triple PD and what are the characteristics of it? So we use the Barony Society criteria for diagnosis of triple PD, where the following are the criteria used. The time frame of the symptoms must be present for most of the days for more than 3 months. The symptoms may be of a waxing and waning nature. It must be a persistent unsteadiness or a rocking sensation or a non-spinning dizziness. It is exacerbated by certain upright posture, active or passive motion, or a moving visual stimuli or complex patterns. It is also precipitated by an acute vestibular or a medical or a psychological event. So the diagnosis also requires significant functional impairment and it cannot be better explained by another disease. We assess the severity using the dizziness handicap inventory or the patient health questionnaire. So this is the Barony Society criteria for diagnosis of triple PD, which is the persistent postural perceptual dizziness, which I have explained that the symptoms must be present for most of the days. Symptoms are exacerbated by a psychological event and they cause functional distress and impairment, and they are not better accounted for another disease or disorder. The dizziness handicap inventory, which we use, consists of 25 questions, and based on the score, we classify as 16 to 34 includes mild handicap, 36 to 52 will be moderate handicap, and a score of beyond 54 indicates severe handicap. Patient health questionnaire is a routine questionnaire we use in screening patients for any comorbidities. Best depression inventory is a scale we use for depression, as well as Hamilton Anxiety Depression Scale can be used in both depression and anxiety. So the patient health questionnaire includes of questions like this, where little interest or pleasure in doing things, or a feeling of feeling down, depressed or hopelessness. Then we use ask about their sleep, when they have trouble falling or staying asleep, or are they sleeping too much, feeling tired or having little energy, poor appetite or overeating, feeling bad about yourself, or feelings that you are a failure, or you have let yourself down or your family down. Trouble with concentration on things such as reading, watching television or watching shows, moving or speaking so slowly that other people have noticed, or the opposite, where they are being very fidgety and restless and moving around a lot of the time. And the last criteria is for suicidal thoughts, where they have thoughts that they would be better off dead or hurting themselves in some way. Based on the symptoms, we score them from not at all to several days, more than half of the days, and nearly every day. So it's a quick screening technique to understand any comorbid psychiatric problems. One thing we have to understand is, we very often see that if a concept of psychological concept comes, people feel that it is just purely in the mind, it is all emotional, and many a times the patients are dismissed, saying that they are malingering, they are faking it, or they are untreatable. But we have to know that the symptoms are 100% real, and functional does not mean that it is imagined. It is a failure in the processing. So it's a software gadbad rather than a hardware. And functional vertigo, or triple PD, is a recognized and a chronic neurovestibular disorder, and it is driven by altered sensory integration, faulty threat processing, and maladaptive balance control. So we'll understand how this happens. So this is the explains how the functional vertigo develops. So first, the patient will have an acute trigger. So he can have an acute BPPV, or a medical illness, or a panic attack, where they experience the symptoms of dizziness. These symptoms, they experience heightened vigilance when their attention shifts to these symptoms. So even minor symptoms, their attention becomes a lot towards these symptoms, and it leads to balance, hypersensitivity to inner ear signals. The patients will then undergo catastrophic misinterpretation. Then they feel that their symptoms are something very huge and something bad is about to happen to them. Then they develop protective responses, which is the avoidance behavior. They start avoiding factors which led them to experience these symptoms. So the brain constantly locks in a chronic threat state. What are the vulnerabilities? So vestibular triggers can happen when there can be BPPV, vestibular neuritis, vestibular migraine, or even head injury, concussion. Non-vestibular triggers like panic attacks, any stressful life events, prolonged bed rest, any medical trauma. Predisposing vulnerabilities like we discussed, female gender, pre-existing anxiety, depression, motion sensitivities, people who have a perfectionist nature, and short sleepers. So functional vertigo is rarely just structural or purely psychiatric. It is usually an intersection of both a physical trigger as well as a sensitized nervous system. Before we diagnose as functional vertigo, we have to rule out the red flags and other medical emergencies. So neurological emergencies like focal neurological deficits, symptoms like severe new headache which can suggest a stroke, acute ataxia or inability to stand, and progressive neurological signs. Then ocular symptoms like direction changing or vertical nystagmus or diplopia. Even cardiovascular emergencies like syncope, chest pain, palpitations, vascular risk factors can also present with vestibular syndrome. So a functional diagnosis cannot be done unless we exclude all these urgent causes, and we cannot diagnose a triple PD without a careful bedside examination. So in a bedside examination, which is our most powerful tool, what things we can test? In eyes, we can test about nystagmus, smooth pursuit, then Dix Hulpike maneuver whenever required. In ears, we have to assess the hearing, we have to use otoscopy. Systemic examination like blood pressure, orthostatic blood pressure. Neurological examinations include cerebral examination and general neurological examination. We should also test their posture through Romberg's test or through gait assessment. So a careful bedside examination is often more useful than routine imaging in common vertigo presentations. Even though BPPV may be the trigger, but triple PD becomes the chronic residual syndrome. Now, how do we differentiate between the different types of dizziness? So, peripheral causes like BPPV or neuritis, central causes like stroke, and functional, which is triple PD. So, the dizziness which happens in peripheral, it is the spinning vertigo type. In central causes, when if it's a stroke or tumor, it is severe imbalance. There will be neurological deficits, and in triple PD, it will be rocking, swaying, or non-spinning unsteadiness. This starts episodic or acute. A stroke can also be acute or progressive, but triple PD will be a chronic course, a daily course. It may have a waxing and waning nature. Any triggers, it can be specific head positions or changes. A central cause will be independent of any movements, and triple PD will have triggers like upright posture or complex visuals and motions. In examination findings, we'll find nystagmus, abnormal head impulse. In central causes, we'll find direction changing nystagmus or severe ataxia. In triple PD, we'll find normal or nearly normal and highly visual dependent dizziness. So like we discussed, if there are red flag signs, we have to first exclude it, like neurological deficit, any direction changing nystagmus, any new hearing loss, diplopia, dysarthria or dysphagia, any acute ataxia. The rationale for investigations, if we suspect a central cause or progressive neurological signs, then an MRI brain is indicated. If we do not suspect any of these symptoms, so, and the position, and it's a typical benign positional dizziness, so imaging is not routinely indicated. So functional diagnosis requires safe exclusion of urgent causes, but if we have a routine overscanning, we advise every patient to undergo scans, MRIs, it reinforces the patient's health anxiety. So the ghost of the triggers, BPPV many times overlaps with triple PD. So first, the patient may present with an acute BPPV. They may experience a brief spinning vertigo, which is triggered by head movement. Dix-Hallpike positive. They are treated effectively with the Epley maneuver. So the BPPV is treated, they are better. But the spinning stops, but the patient's nervous system remains on high alert. And they go for repeated scans or repeated doctors, and all of that comes as completely normal. And eventually they develop the chronic triple PD where they feel a persistent rocking sensation. They start avoiding factors which can cause this. So they start avoiding going to malls, they completely avoid bus travels, they avoid movies where have complex visuals. So treating the structural trigger, if we treat the BPPV, does not automatically eliminate the functional after effect. BPPV is supposedly the match, but triple PD is ultimately the forest fire. I would like to discuss certain cases which we routinely observe, which presents with psychological comorbidities along with triple PD. So my first case was a case of panic disorder with agoraphobia. Mr. Chandrasekhar was a 30-year-old IT professional. He was a single male living alone in Mumbai, and his family was in Meerut, UP. He experienced the first episode of vertigo in April 2020 when there was the COVID lockdown, and he couldn't access any doctor. The vertigo was self-limiting, he got better, he took a paracetamol, he was okay. But following this, he started with excessive Google research about vertigo. He started being preoccupied with vertigo. He felt that something severe will happen, or it is a fatal illness which he might develop. He also started experiencing symptoms of panic. Multiple investigations were done, multiple doctor visits were done. He started seeking reassurance from people. He started avoiding travel completely, especially when he was alone. We also observed that he was anxious and had an overthinking personality. Our second case was of a female we diagnosed with a somatic symptom disorder. Mrs. Sushila was a 50-year-old married housewife, and she complained of chronic daily dizziness. It was resistant to treatment. All specialist references were done, so MRI scans, lab investigations, ENT evaluations, all had been inclusive, which we had seen in the start of a FAT file. She also gave complaints of headache, back pain, fatigue, sleep disturbances, then other somatic complaints like bloating, constipation and pelvic pain. She denied any other mood symptoms of sadness or anxiety and gave a good response to antidepressants. Another case we had of PTSD, which is a post-traumatic stress disorder, where a 27-year-old single engineer female, she had a first vertigo episode in Dubai when she was traveling from USA to India. So she had a long duration flight where she first experienced vertigo. She also had severe nausea, vomiting, imbalance, and more on the right side, and a documented nystagmus. She then had to be admitted in the airport hospital at Dubai and could only reach India after 5 days. All her investigations were normal and she was diagnosed as vestibular neuronitis. But there was intense anxiety associated with episodes of dizziness. So there was anxiety about anxiety. So she started fearing the vertigo attacks. She started fearing how she will experience that. After coming back, she also developed intrusive memories. There was fear of hospitals. She started having nightmares around the theme of emergency hospitalization. She started avoiding all situations that may cause giddiness or anxiety. She started avoiding traveling, and there was a lot of fear, intense fear of another vertigo attack. Certain phobic disorders also are seen commonly. So there is a phobic postural vertigo where they complain of postural dizziness. There is a lot of fear about fall. So patients commonly repeat that we may fall and we feel a lot of fear surrounding that. There is no falls as such. They start avoiding the triggers. This again improves with exercise or alcohol. We observe frequent OC traits. And there is hypersensitivity to proprioceptive disturbances. Your vestibular exercises or occupational therapy exercises have shown to be beneficial. Conversion episodes where we saw a 20-year-old married woman who had dizziness and brief loss of consciousness. She also had occasional falls, and all these episodes may specially occur after altercations in her family. The La Belle indifference, where the patient had no subjective difference towards her symptoms. She was completely normal with respect to her symptoms. There was also disturbed sleep and anxiety, and one episode of a pseudo seizure. One past episode she had of a possession spell, and they had all responded well to faith healing. On detailed inquiry, we found that there was marital discord, there were strained relations with her in-laws and external families, following which these symptoms would start. There was also a case of depression where we found triple PD. So Mr. Prakash, a 65-year-old banker, he had a known case of hypertension, diabetes mellitus. He had episodes of giddiness, loss of balance, but all neurological and ENT evaluation were normal. He reported of a pervasive, persistent sadness of mood, a loss of interest, and crying spells. He had difficulties with memory, concentration. He also started having a lot of guilt about being a burden on his family. They started developing fear of falls and being bedridden. He started giving death wishes that he would be better off dead. There was weight loss around 10 kgs over the past 6 months. He reported sleep disturbances with early morning awakening. We started him with antidepressants as well as CBT, and it showed significant improvement. A last case of malingering where we found a female, 35-year-old. She would report of a chronic persistent dizziness and waxing and waning course, and it would tend to increase during the summer months. All investigations were within normal limits. There was partial response to all treatments, which was short-lived, and there was acute exacerbation of vertigo, and it would respond immediately to hospitalization or just a saline infusion. All psychiatric evaluation was within her normal limits. We found that she had a passive-aggressive personality style. So there were a lot of quarrels with her in-laws, and she would experience these symptoms following that. So the treatment modality, so like Neha ma'am has in AIB, we require multiple specialists for treatment of triple PD. So the role of ENT and neurology first to exclude any peripheral or central pathologies, to treat the BPPV and other otological diseases, to assess for vestibular migraine. Then comes the role of physiotherapy, where we use vestibular rehabilitation exercises, graded exposure. We treat them habituation to movements. Concurrently, psychiatric and psychological help to treat the anxiety, panic, any trauma, to address the avoidance and hypervigilance. So CBT plays a key role in these symptoms. Most importantly, what we all have to learn how to communicate with such patients. So many a times people may unknowingly tell to the patients that all your tests are normal, there is nothing wrong with you, it's only anxiety, it's only in your head, you get strong mentally, all this doesn't happen. So what this type of conversation does is that the patient feels dismissed. They start seeking second opinions. This intends to worsen their symptoms. It increases their hypervigilance. So what are some things which we can tell them is, your symptoms are very much real and you have a condition called as functional dizziness or triple PD. Just naming the disorder gives them a sense of relief that yes, there is certain diagnosis. your balance system has become overprotective after an initial trigger. So we explain them that the initial symptoms may be of BPPV or other vestibular causes, but now your mind is becoming overactive to all your symptoms. Your brain is maintaining the symptoms through the hypervigilance. And all of these type of communication, it validates the patient, it improves their engagement, and this has a role in a part to rehabilitation. Certain pharmacotherapy also plays a role where we have used SSRIs like escitalopram in the doses of 10 to 20 milligrams. When there's severe anxiety, we've also used paroxetine in the doses of 25 to 37.5 milligrams. Certain SNRIs also play a role like venlafaxine and desvenlafaxine, and tricyclic antidepressants like amitriptyline plays a very good role in vestibular migraine. Occasional benzodiazepine use is for panic attacks. We have to make sure that the patient discontinues it so that there is no dependence on the benzodiazepines. So cognitive and behavioral toolkit which we usually explain is the breathing technique. This the patient can commonly follow. So we teach them the 4-second breathing rule, where he has to breathe in for 4 seconds, then he has to hold the breath for 4 seconds, breathe out for 4 seconds, and then hold again for 4 seconds. So we usually advise at least 4 to 5 counts of this breathing technique when they are experiencing severe anxiety or any episodes of dizziness. What it does, it lowers the locus coeruleus activation, and it grounds them and takes their focus away from the dizziness. Certain sensory grounding techniques which also they can do very easily in moments of distress is we ask them to see 5 things which they can see, to name 4 things they can touch, or 3 things which they can hear, 2 things which they can smell, and 1 thing which they can taste. So 5, 4, 3, 2, 1. This shifts the focus from their symptoms to the external reality. Vestibular rehabilitation and graded exposure, which others will definitely cover. So includes exercises where gaze stabilization is done, balance exercises are done. Then there is graded exposure to the provocative head movements. This reduces the postural strategies. Gradually the patients are reinforced into the environment where they experience the dizziness, and eventually the target is for a functional return where they have to resume their driving, their work, their daily activities without any safety behaviors. Most important thing is to not prescribe avoidance. So once we start these exercises, the patient may develop dizziness and they will say, okay, we don't want to do this, and they will avoid doing that. But avoidance actually worsens their dizziness. So we have to train them to experience the symptoms consistently so that their rehabilitation is better. So the step-by-step algorithm which we follow is, first we of course access for the red flags. Then we treat the triggers. If there are any BPPV, we treat that. We identify the residual symptoms. If the symptoms persist for more than 3 months with other triggers, we assess for triple PD. We validate the patient. We explain them how triple PD develops, what the functional mechanism is. Then we deploy the triad, that is the vestibular rehabilitation exercises, CBT along with medications if required. And the functional goal setting is to focus on follow-up so that the patient restores their daily life activities, not just the elimination of dizziness, but restoring their day-to-day activities. The 8-step algorithm, where again is the similar thing. We identify the red flag signs, we perform a bedside neuroexamination, then we diagnose and treat the causes. 4th point is where we assess for triple PD. Then we explain the functional mechanism, how triple PD develops. This validates the patient. We initiate the triad of vestibular rehabilitation, CBT and psychological treatment, add medications if necessary. In our follow-ups, we focus on the functional restoration and not just symptom tracking. So key takeaways from today's topic will be that the symptoms are very much real, the disorder is real, it's a valid, disabling and treatable neurovestibular disorder. It's not just an imagined disease or in their mind. Triple PD is the standard, so we have to look for the triad where there is persistent dizziness, upright postural exacerbation and visual complexity triggers. We have to also look for the overlap where triggers like BPPV, they initiate the triple PD. So we have to treat the trigger, but it cannot extinguish the fire, it cannot manage the triple PD. And of course, like ARV works, it is a team approach, so we require multiple specialists, including ENT, neurologist and physiotherapist for the validation for vestibular rehab as well as psychological tools, not just medications. Thank you.
So thank you, Dr. Suraj, once again for the exceptional lecture. Suraj is open for questions. If you have any, please ask him.
I am told that we should not leave you without asking about anxiety, so kindly throw some light.
Rescue mechanism.
Okay. So first is to identify if a person experience, you are asking in a broader term or in just a triple PD concept?
No, it just.
You can narrate both now.
Okay. So in triple PD, usually the anxiety is predominantly related to dizziness. So where they have ki I will fall or I am experiencing a lot of dizziness. Nobody is understanding this, and what they do is usually in that step is they stop doing the activity. So if they experience it while traveling or while doing some activity, they completely stop it. So the first step I do is to explain to them that these are the symptoms, they are just the symptoms of anxiety, and your inner ear is normal, your other mechanisms are normal. You avoiding the triggers will cause a lot of problem. You avoiding, you seeking safety, time being it will help you, but in the longer run it will cause you a problem. And the techniques which I just showed, so the breathing techniques to use in the times of crisis, the grounding techniques to use to count things around them, to see things around them, and just try to be in the present. Our target is to shift their focus from the symptoms to the present, because of the focus on the symptoms, they tend to experience a lot of anxiety. And gradually, repeated sessions to understand how the brain works, why they get more anxious. We do that in the follow-up sessions.
Sir, one of the slides shows alcohol shows some improvement in triple PD.
No, exercise and occupational therapy.
Please show that
No,
slide.
I'll answer.
Please show that slide.
Alcohol helps in reducing the symptoms of vertigo
Achha.
because it's a natural suppressant, na?
It is some
So we have something known as alcohol intoxication syndrome. So if anyone who's alcoholic and comes the next day, which I'm sure my neurologist Dr. Dinesh Singh is coming, and we have seen a lot of ethanol toxicity. So and then we give Thiamine above that. So you can ask that question, keep it open for him. So at that time they feel better. Why? Because actually they're suppressing their vestibular apparatus. And any suppressant for that matter, because I was going to answer this question in the pharmacotherapy when I'm going to take that topic. So there are many drugs which are suppressant, so they feel better because they are out of the world. There are 4 systems that vertigo get affected in. One is histamine, serotonin, cholinergic and dopaminergic. So what goes off is serotonin and alcohol. So they are happy, no? So that's a temporary relief. But then again the real world and the hangover. So he must have mentioned that he was getting relief by that at that point of time, but not forever, which he explained. Yeah. Sir, we will discuss in the hands-on. Let's release Suraj from the hands-on. We are here to answer that.
So generally, patients are quite skeptical when we try to refer it to a psychiatrist.
Yeah.
So how do we persuade them to visit you in an easy term? They are ready to visit an ENT, a neurophysiotherapist, but what about a psychiatrist?
Correct. So I think I learned this from Neha ma'am itself. Like she tells them he will just counsel you and he'll help you with the anxiety, and she explains the mechanism of triple PD, how it is with the brain as well as with the mind. So a holistic approach will help you. Not directly mentioning psychiatrist or medications that he will start you with medication or something. He'll start you with CBT and he'll help you understand the symptoms and try taking a session and see. You've done all your investigations, all reports, everything has come normal. You just take a session and see.
So basically when your patient comes up, you have to, when you are sure and everything else is done, don't label, first of all don't label them initially as functional. That I don't do.
Yes.
Probably not neither because I tell him like whatever it is. You need to get the confidence of the patient to treat you. This is doctor-patient relationship. I mean, this is, you have to be very open with the treatment. And you have to make them realize, because their files are always 4-5, that everything else has failed. Na? So what is left? Diagnosis of exclusion? That is sometimes other way around is also an option, So give them that and tell them. And you know what? They basically know that. They're just beating around the bush.
Symptoms through the hypervigilance. And all of these type of communication, it validates the patient, it improves their engagement, and this has a role in a part to rehabilitation. Certain pharmacotherapy also plays a role where we have used SSRIs like escitalopram in the doses of 10 to 20 milligrams. When there's severe anxiety, we've also used paroxetine in the doses of 25 to 37.5 milligrams. Certain SNRIs also play a role like venlafaxine and desvenlafaxine, and tricyclic antidepressants like amitriptyline plays a very good role in vestibular migraine. Occasional benzodiazepine use is for panic attacks. We have to make sure that the patient discontinues it so that there is no dependence on the benzodiazepines. So cognitive and behavioral toolkit which we usually explain is the breathing technique. This the patient can commonly follow. So we teach them the 4-second breathing rule, where he has to breathe in for 4 seconds, then he has to hold the breath for 4 seconds, breathe out for 4 seconds, and then hold again for 4 seconds. So we usually advise at least 4 to 5 counts of this breathing technique when they are experiencing severe anxiety or any episodes of dizziness. What it does, it lowers the locus coeruleus activation, and it grounds them and takes their focus away from the dizziness. Certain sensory grounding techniques which also they can do very easily in moments of distress is we ask them to see 5 things which they can see, to name 4 things they can touch, or 3 things which they can hear, 2 things which they can smell, and 1 thing which they can taste. So 5, 4, 3, 2, 1. This shifts the focus from their symptoms to the external reality. Vestibular rehabilitation and graded exposure, which others will definitely cover. So includes exercises where gaze stabilization is done, balance exercises are done. Then there is graded exposure to the provocative head movements. This reduces the postural strategies. Gradually the patients are reinforced into the environment where they experience the dizziness, and eventually the target is for a functional return where they have to resume their driving, their work, their daily activities without any safety behaviors. Most important thing is to not prescribe avoidance. So once we start these exercises, the patient may develop dizziness and they will say, okay, we don't want to do this, and they will avoid doing that. But avoidance actually worsens their dizziness. So we have to train them to experience the symptoms consistently so that their rehabilitation is better. So the step-by-step algorithm which we follow is, first we of course access for the red flags. Then we treat the triggers. If there are any BPPV, we treat that. We identify the residual symptoms. If the symptoms persist for more than 3 months with other triggers, we assess for triple PD. We validate the patient, we explain them how triple PD develops, what the functional mechanism is. Then we deploy the triad, that is the vestibular rehabilitation exercises, CBT along with medications if required. And the functional goal setting is to focus on follow-up so that the patient restores their daily life activities, not just the elimination of dizziness, but restoring their day-to-day activities. The 8-step algorithm, with, again, is the similar thing. We identify the red flag signs, we perform a bedside neuroexamination, then we diagnose and treat the causes. 4th point is where we assess for triple PD. Then we explain the functional mechanism, how triple PD develops. This validates the patient. We initiate the triad of vestibular rehabilitation, CBT and psychological treatment. Add medications if necessary. In our follow-ups, we focus on the functional restoration and not just symptom tracking. So key takeaways from today's topic will be that the symptoms are very much real, the disorder is real, it's a valid, disabling and treatable neurovestibular disorder. It's not just an imagined disease or in their mind. Triple PD is the standard, so we have to look for the triad where there is persistent dizziness, upright postural exacerbation and visual complexity triggers. We have to also look for the overlap where triggers like BPPV, they initiate the triple PD. So we have to treat the trigger, but it cannot extinguish the fire, it cannot manage the triple PD. And of course, like ARV works, it is a team approach, so we require multiple specialists, including ENT, neurologist and physiotherapist for the validation for vestibular rehab as well as psychological tools, not just medications. Thank you.
So thank you, Dr. Suraj, once again for the exceptional lecture. Suraj is open for questions. If you have any, please ask him.
I'm been told that we should not leave you without asking about anxiety, so kindly throw some light.
Rescue mechanism.
Okay. So first is to identify if a person experiences, you are asking in a broader term or in just a triple PD concept?
No, it just.
You can narrate both, na? Huh.
Okay. So in triple PD, usually the anxiety is predominantly related to dizziness. So where they have I will fall or I am experiencing a lot of dizziness. Nobody is understanding this, and what they do is usually in that step is they stop doing the activity. So if they experience it while traveling or while doing some activity, they completely stop it. So the first step I do is to explain to them that these are the symptoms, they are just the symptoms of anxiety, and your inner ear is normal, your other mechanisms are normal. You avoiding the triggers will cause a lot of problem. You avoiding, you seeking safety, timing, it will help you, but in the longer run it will cause you a problem. And the techniques which I just showed, so the breathing techniques to use in the times of crisis, the grounding techniques to use to count things around them, to see things around them, and just try to be in the present. Our target is to shift their focus from the symptoms to the present, because of the focus on the symptoms, they tend to experience a lot of anxiety. And gradually, repeated sessions to understand how the brain works, why they get more anxious. We do that in the follow-up sessions.
Sir, one of the slides shows alcohol shows some improvement in triple PD.
No, exercise and occupational therapy.
Please show that
No,
slide.
I'll answer.
Please show that slide.
Alcohol helps in reducing the symptoms of vertigo because it's a natural suppressant, na?
It is some
So we have something known as alcohol intoxication syndrome. So if anyone who's alcoholic and comes the next day, which I'm sure my neurologist Dr. Dinesh Singh is coming, and we have seen a lot of ethanol toxicity. So and then we give Thiamine above that. So you can ask that question, keep it open for him. So at that time they feel better. Why? Because actually they are suppressing their vestibular apparatus. And any suppressant for that matter, because I was going to answer this question in the pharmacotherapy when I'm going to take that topic. So there are many drugs which are suppressant, so they feel better because they are out of the world. There are 4 systems that vertigo get affected in. One is histamine, serotonin, this cholinergic and dopaminergic. So what goes off is serotonin and alcohol. So they are happy, no? So that's a temporary relief. But then again the real world and the hangover. So he must have mentioned that he was getting relief by that at that point of time, but not forever, which he explained. Yeah. Sir, we will discuss in the hands-on. Let's release Suraj from the hands-on. We are here to answer that.
So generally, patients are quite skeptical when we try to refer it to a psychiatrist.
Yeah.
So how do we persuade them to visit you in an easy term? They are ready to visit an ENT, a neurophysiotherapist, but what about a psychiatrist?
Correct. So I think I learned this from Neha ma'am itself. Like she tells them he will just counsel you and he'll help you with the anxiety, and she explains the mechanism of triple PD, how it is with the brain as well as with the mind. So a holistic approach will help you. Not directly mentioning psychiatrist or medications that he will start you with medication or something. He'll start you with CBT and he'll help you understand the symptoms and try taking a session and see. You've done all your investigations, all reports, everything has come normal. You just take a session and see.
So basically when your patient comes up, you have to, when you are sure and everything else is done, don't label, first of all don't label them initially as functional. That I don't do.
Yes.
Probably not neither because I tell him like whatever it is. You need to get the confidence of the patient to treat you. This is doctor-patient relationship. I mean, this is, you have to be very open with the treatment. And you have to make them realize, because their files are always 4-5, that everything else has failed. Na? So what is left? Diagnosis of exclusion? That is sometimes other way around is also an option, So give them that and tell them. And you know what? They basically know that. They're just beating around the bush.
Like, if you would like to send some patient for the rehabilitation, what symptoms mostly you experience that should be treated with VRT?
Anxiety.
And
Vertigo. Anything which lasts over 3 weeks.
okay.
Because they need lot of rehabilitation.
fear of fall.
Mostly the vertigo here being the common symptom, and later the other things are dizziness, the risk of falls, motion sensitivity, and other things like imbalance. So today, before we get into any specific exercises or any specific protocol, I would like to just let you know how these exercises even help, how they even work, like that is going to help you to reason out the treatment and not just follow a particular protocol. So here, let's see a big picture. So coming, like recovering from a vestibular deficit, it's not just about the inner ear healing, it's about how your brain compensates for the loss. And this loss compensation happens through neuroplasticity. Everybody knows about neuroplasticity, that is the brain's ability to relearn everything. So the relearning is not an automatic process. The brain has to learn new strategies, and the learning is fed by the input of sensory motor आपका input. Like you have to give a task to the brain, a different task that it learns, because it has the capacity to change the way it is reliable on the other system like vision, your somatosensory inputs, and other things like whatever the residual vestibular existing reflex is existing. So to relearn this process, we need, have I covered? Yes. So to relearn this process, the whole cognitive learning, we have to give the brain the sensory input, which is executed only when you have a physical capacity to execute the function and a dedication and motivation to execute it, because the whole thing, that is cognition here, the attention and activity engagement, it accelerates the process of relearning whatever we want to. Okay, because why I am saying this, because if we give a patient a particular protocol which is very perfect but he is not consistent about it, so we won't get a desired result as we give a minimal protocol to a patient who is consistently following it. So to achieve all this thing, like achieving the compensation of your brain is mediated by all these things like the hybrid approach. Why we call this as an hybrid approach? Because no particular strategy fits every patient. So we have to decide on, like you have to decide on what the deficit is demanding. So the first thing we see here is adaptation. So adaptation is the first lever. It targets the long-term change in the neuronal firing rate of the vestibular system in response to the head movement, with the goal of reducing the retinal slip. And this is what the VOR1, the vestibular ocular reflex exercise VOR1 and VOR2 are built around. For an example, let's consider a patient of vestibular neuritis. The VOR gain on the affected side is reduced. So when the patient turns the head, the eyes lags behind and the world appears to jump. That is what we call the oscillopsia. In this case, we have one thing to train, that is the VOR. How we do the VOR exercises as an adaptation exercise. Here is an example of VOR1 exercises. These exercises are extremely important to improve the gaze stabilization and thus improve your balance. So how do we do it? Initially we start the VOR exercises in sitting position so that the patient becomes comfortable. In sitting, we have to hold a target at arm length and fix your vision on the target and slowly move your head right and left initially a slow movement and then you can increase the repetition. You have to do all these things straight away for a minute. This can improve, this can increase your dizziness a bit, but that is normal because something that is stimulating the provocating symptom is okay. So this exercises, the VOR exercises can be done in various positions. Initially starting with the sitting position, then in standing, then in the tandem position, then in standing on a foam. Like for example, changing the base of support will give more target to the brain to learn things. So there is a process of sequence in progression. We start with sitting, then standing together with the standing with feet together, then tandem, and then single leg. Firm surfaces to foam surfaces, and then with the eyes closed. We first start with the horizontal movement, then with the vertical, and then you can move on to the diagonal one. And then you can start with the random diagonal directions. So initially you have to start it slow and then fast. You can also sorry. You can also perform with the target far from you and then doing the exercises of VOR1. These all are progressions of the VOR1 exercises. You can always change the background to give it more challenges. You can put a checkered background or anything, normal papers. This is a further progression of the exercises, but you have to decide. Like there are phases which are theoretical, like you have to do in phase 1 in sitting, but you have to judge by yourself if the patient is even able to do that exercises in sitting, and then when the next week comes, is he even ready for the standing exercises. So you have to judge on your own, because patients who have been given home exercise program, VOR as in home exercise program, they are not really doing it, but you have to judge on assessment when the patient comes to you. So according to that, you have to decide whether you want to progress from exercise 1 to exercise 2. After this, when you have when you see there is no other problems with VOR1, like patient is adapted to those exercises, then only you can move on to VOR2. Now in VOR2, what we do? Now we keep again the object at an arm distance. Now this time we move the head and your target exactly in opposite directions. I just play the video. The patient is asked to hold the target in their vision and then move their neck and target in opposite directions. These are the exercises very, very, very important to improve your gaze stabilization, in order to improve your balance and other things. This is an example in the standing. This is a tandem example. This is an example on a foam. Actually in the video, these exercises are very simple to see, but when a patient with vestibular dysfunction is doing those exercises, you will see the difference, how it is difficult for them to even do a sitting exercise. So we'll move on to the next topic. I'll repeat the slides next when we do the hands-on techniques. So the habituation. Now let's consider an example of a patient who is having residual disequilibrium after BPPV or motion provoked dizziness not explained by a fixed hypofunction. repositioning maneuver either don't apply or they aren't enough, and there's no way or gain to recalibrate. What we need instead is to blunt the brain's response to a specific provoking movement, and that is habituation. So habituation, the repeated side-to-side head movement turns at increasing speed and amplitude progressively desensitize the provoking position and movement. Like you might have seen patients with unilateral vestibular hypofunction complaining about any movement that can trigger their symptoms. Like even they are turning while they are sitting, that can trigger their functions. So you have to repeatedly give them an exposure to those movements so that the brain understands one thing, that these stimulations are not threatening. So the brain learns all these things over a period of time and then relearns other things after that. So you can always progress exercises related to this. See, these are some exercises. These are some rotations, but these are progressive exercises. I don't have the videos for the basic exercises. You can just start with patients sitting on a chair, bending forward, moving their head up and down, moving their head side to side, and normal eye movement in sitting position and tilts and whatever. Say for example, patient sitting at home may require to take out the laundry clothes. So those are the movement they avoid because of the provocation of symptoms, because of the movement. So you have to evaluate the patient on the basis of their complaints. If particular thing is causing them increasing their symptoms, so you have to just examine the patient, assess for the symptom, and then manage the program of exercises, and then you decide whether which protocol you want to give the patient. So in case of this, the basic exercises what we do is Brandorf maneuvers, like that gives you a habituation exercise, you sit up, I think physios must know the Brandorf exercises. Okay. So the procedure is you sit up on the edge of the table or a bed, you turn your head 45 degrees to one side, lower onto the opposite side of the body, keeping the head turned, legs up on the surface. Hold until the symptoms subside, hold for 30 seconds or maximum up to 2 minutes, and then return to the sitting position, head back to the midline and repeat on the opposite side. These are the exercises that helps you habituate the symptoms that are provoking your symptoms. These are some exercises. So these are some activities that are used in daily life, like bending forward and grabbing something from the floor. Ladies usually working in kitchen, they have to repeatedly move right and left doing tasks. You can always progress the exercises by changing the surface you are standing on. These exercises are progressively challenging, and thus it helps you to retain the balance and improve the gaze stability. In those exercises, you just have to add on things like giving cues to the patient. Like if a patient is simply just doing the exercises, he won't be learning things. You have to add on cognitive cues to that, like hold it, lift it, look at me, tell me what it is. So that adds on the cognitive part of it. So substitution exercises are now how substitution works. Now take an extreme example. A patient with bilateral vestibular hypofunctions, say from ototoxicity, There's no residual VOR gain left on either side to recalibrate. So adaptation has nothing to work with. Instead, we train the brain to substitute other strategies for the missing reflex. Compensatory saccades and central pre-programming. For example, I would like to tell you an example for this. Imaginary target exercise. We ask the patient to fix their gaze on a particular target. Then we ask the patient to occlude one eye. Then we ask them to imagine that they have their eyes fixed on the target. Now you close your eyes and move your head. Now imagine that you still are on the target. So these are the exercises that recalibrate the brain and compensate at the upper level, like central level. So clinically, why it matters? When the VOR can't fully stabilize the vision, patient develops a compensatory saccades to refix it on the target. Substitution training makes these strategies more consistent and efficient for the daily life tasks involving quick gaze shift by visual environment. So, why VOR wouldn't work here? Can anybody tell me? Because there is no VOR gain to adapt. Bilateral system is deficit on that part. Okay, so the whole thing, the last category is, these are some exercises. We will be discussing all these exercises on hands-on technique also. So, on the cognition part, this is the last category. The patient who don't fit in a clean peripheral lesion at all. Take some cases with, as sir said about the triple PD. Vestibular tests are normal, but they are functionally disabled by dizziness, especially in a busy and visual environment or when multitasking. Standard adaptation, habituation, substitution exercises often don't move here because the deficit isn't peripheral. It's how the brain allocates attention between motor control and cognitive loading. So, though in this case we give patients exercises that includes dual task training. Volunteer stands in a single leg stance or walk straight line. We can add cognitive load, serial subtraction, count back from 100 by 7s and respond to the random auditory cues while moving. Have them rotate their head towards unpredictable auditory stimuli while maintaining balance, combining with motor and cognitive demands simultaneously. Observe how motor performance degrades under cognitive load. That's visible drop is teaching the movement. Now, why this clinically matters? Vestibular disorders often involve cognitive motor interference that impairs daily functioning and increases the risk of fall. Dual task training significantly improves performance by reducing the interface. So the cognition as its own pillar rather than so cognition alone works well to other functions like adaptation, substitution and habituation. Without cognition, these three systems can't work at its best. So the takeaway messages are: the brain cannot fix what it cannot see. So visual feedback must be present at the challenge during every exercise. No movement is no improvement. Adaptation only occurs under active, repeated movement-driven stimulus. Focus and concentration makes it better. Attention amplifies plasticity. Distracted repetition yields weaker gains. Cognition, the most powerful tool in vestibular rehabilitation therapy. Engagement and motivation predicts long-term outcome more than exercise alone. Thank you. Any questions?
Divya, we'll be taking your, of course we have a hands-on and we have a very detailing to talk about
Yes.
the last 4 points that we have
Exercise, yes.
told. So, Thank you so much for giving this lecture. And of course, there is a lot to be known, but it will be
Yes.
more on the hands-on when we actually
Yes.
do it. So I would request Ajay Gupta from Agilis.
Triple PD. Vestibular tests are normal, but they are functionally disabled by dizziness, especially in a busy and visual environment or when multitasking. Standard adaptation, habituation, substitution exercises often don't move here because the deficit isn't peripheral. It's how the brain allocates attention between motor control and cognitive loading. So, though in this case we give patients exercises that includes dual task training. Volunteer stands in a single leg stance or walk straight line. We can add cognitive load, like serial subtraction, count back from 100 by 7s and respond to the random auditory cues while moving. Have them rotate their head towards unpredictable auditory stimuli while maintaining balance, combining with motor and cognitive demands simultaneously. Observe how motor performance degrades under cognitive load. That's visible drop is teaching the movement. Now, why this clinically matters? Vestibular disorders often involve cognitive motor interference that impairs daily functioning and increases the risk of fall. Dual task training significantly improves performance by reducing the interface. So, the cognition as its own pillar rather than so cognition alone works well to other functions like adaptation, substitution and habituation. Without cognition, these three systems can't work at its best. So the takeaway messages are: the brain cannot fix what it cannot see. So visual feedback must be present at the challenge during every exercise. No movement is no improvement. Adaptation only occurs under active, repeated movement-driven stimulus. Focus and concentration makes it better. Attention amplifies plasticity. Distracted repetition yields weaker gains. Cognition, the most powerful tool in vestibular rehabilitation therapy. Engagement and motivation predicts long-term outcome more than exercise alone. Thank you. Any questions?
Divya, we'll be taking your, of course we have a hands-on and
Yes.
we have a very detailing to talk about
Yes.
the last 4 points that we have
Exercise, yes.
told. So, thank you so much for giving this lecture. And of course, there is a lot to be known, but it will be
Yes.
more on the hands-on when we actually
Yes.
do it. So, I would request Ajay Gupta from Agilis. As such, Dr. Dinesh Singh is a very renowned neurologist, one of the youngest and probably the top-notches India can ever see in terms of neurology. Please give him a big applause. And next 20 minutes will be an excellent extempo on neurology and how the perspectives are. So sir, over to you.
Thanks Dr. Neha for inviting me. It's always a pleasure to be with AIB. We work in close association many times. And I think you discussed all the autological aspects of vertigo. So my talk should be a little easy. They made things easier for me, particularly in terms of nystagmus. So I wouldn't get into details of nystagmus. I'll just show you some videos. We'll keep it very case-based. I thought we'll keep a neurology perspective to my talk. And basically I'm dealing with all dizziness which are dangerous, right? And these are the few cases you shouldn't miss in your clinical practice, is what I'll try to show you. So it's all going to be case-based, no theory. We'll discuss. If she permits, I can probably take about 30 minutes.
Please take it.
I have around 15 cases, if I can finish as much as I'll try to run through. If you have any doubts, please stop me in between and we can discuss it right there, right? Alright, so I'll start off with the take-home message. So all dizziness is not vertigo, that's the first point. Dizziness can be vertigo, dizziness can be stroke, could be of cardiac origin, could be of hemodynamic origin, could be metabolic, something like a hypothyroid, could be Parkinsonism, and could be psychogenic, which I think Suraj has already covered. Vertigo can be fun. We saw all the maneuvers, you saw all the rehab, and it is so rewarding for the patient once they get better after the rehab. But vertigo can be dangerous, particularly if you miss central vertigos. Never miss a posterior circulation stroke. So I'll tell you how to not miss a posterior circulation stroke in clinical practice. Never miss an arrhythmogenic syncope. That's one very, very important point. Most of these patients come with a history of chakkar aa raha, and it's not actually chakkar, and it might be a syncope which can be life-threatening. And if you pick it up on time, probably will save somebody's life. Identify atypical nystagmus. I'm not sure how much they have covered this. I'll just show you what is central nystagmus, and if possible, learn hints. If they have hands-on, I don't know. If they have hands-on, I wouldn't get into too much of hints there. And hints plus, right? So I'll start off with the first case. So this is a young girl whose picnic was cut short. 22-year-old female. She came with headache and chakkar since the last 3 days. So by her general practitioner, she was put on naproxen and anti-vertigo drug combinations. She went for a picnic, but her picnic was cut short. Why? Because she developed difficulty in walking on the 4th day, and she said, my left hand is becoming a little numb. So again, she went back to the family physician. She was treated with vitamin B12 injections, because on examination she had no deficit. She was just saying chakkar aa raha aur ye haath thoda numb ho gaya hai. So she was started on B12 and clonazepam. Considering that 22-year-old में क्या हो सकता है? Might be functional numbness आ रहा है, तो जिधर भी numbness उधर सबको B12 दे दो, so B12 सब कुछ ठीक हो जाता है, like a wonder drug, right? But why she was given B12 and clonazepam? Because she came with an MRI, and that was the MRI which is normal. I think the people at the back, if you can come forward, you will be able to see the things better. So this MRI was normal. There was nothing in the posterior circulation. Whenever you are thinking of chakkar, you will always look at something which is there in the brainstem or in the posterior circulation, right? So the MRI was normal. She came to the physician with an MRI. Now she comes to me, see her video and tell me what's the finding you can see in her. So asking her to look to the right. Now she is looking to the left. So look at her eye movements and tell me what the eye movements are. See, what is it?
Nystagmus.
Correct. What nystagmus?
Vertical.
Vertical nystagmus. Absolutely correct. So what would you like to do next? What's the diagnosis? MRI is normal. And then how do you treat it, of course? So she's got a vertical nystagmus. She's got dizziness since the last 4 days. She's got this hand numbness in the last 4 days with a normal MRI. Can a vertical nystagmus be normal?
No.
Can it be peripheral ever? It cannot be peripheral ever. So what will you do next?
MRI.
Do an MRI again.
angio.
Do an MRI again. MRI angio, yeah, of course. Or you can do an MRI. At least first do an MRI, right? She is 22-year-old, so better to do an MRI. And that was her MRI, which we did at a 3 Tesla place. And if you can see the arrow here, she's got a hyperintensity right at the 4th ventricle area. You can see this? This is not normal. This was not picked up on the first MRI because it was a poor quality MRI. And she had some lesions even in the left temporal lobe. And she had one lesion here in the right parietal lobe, which was the reason of the left hand numbness. So this was basically a case of CNS demyelination. So whenever you come across any dizzy patient, you ask yourself, try to put your diagnosis in such a way. So what's the diagnosis? It is an acute vestibular syndrome. Whether it is peripheral or central? Central. Why central? Because you have a vertical nystagmus and a hemibody symptom. So whenever you have a dizziness or vertigo or whatever with one-sided symptoms, by and large look at central first, because that is something which is completely treatable. Of course peripheral is also treatable, but then you require some medications, and if you don't treat them, they can develop some disability. The diagnosis was a brainstem demyelination, and what was the treatment we gave her? We gave her steroids, we worked her up for demyelination until she turned out to be SLE. Right? So if you would have missed that, it would have been catastrophic. She would have probably developed some other complications of lupus. Now, this is a young chap. He came with a few relatives, 5 relatives got him. 25-year-old male, hypertensive, dizziness with vomiting for the past 3 days, through spins which lasted for minutes to hours, non-positional, with severe persistent nausea, vomiting, sweating, no diplopia, no dysarthria, no hemibody symptoms, and he was on 3 anti-vertigo medications, but he had absolutely no improvement. Vitals were normal, no cerebellar signs, no focal deficits. what is one bedside test you would want to do? This is all bedside. I am not discussing scans. Scans are always going to support your diagnosis. They are not diagnostic. Your examination is diagnostic. So what would you like to examine? Cerebellar sign nahi hai, focal deficit nahi hai. What would you want to see? Rhombus was positive. Okay. What else would you want to see? Hints. Correct. Yes, absolutely. So you would like to see the eyes. You would like to see for nystagmus, right? So look at him. And I think my talk is the last talk, right? So I think you all should be able to diagnose this. No nystagmus on left gaze. Right? So you got a right beating nystagmus. Okay. Now what next? Now you do a yes. So now we are doing a head impulse. So when you turn the head to the right, there is a normal head impulse. This is normal. And when you turn him to the left, it goes and comes back. So what's the diagnosis? A right beating nystagmus with a left HIT positive. What's the diagnosis? This is vestibular neuritis. Which side? जो head impulse positive है, जो side वो है. Not the nystagmus side. Nystagmus is always towards the other side. So the left ear. So he had a left vestibular neuritis. So why didn't he improve? He was on 3 vertigo medication. Why didn't he improve? Because the treatment of vestibular neuritis is steroid. So he improved with steroids. So that is what is important. So again, when you put it in this kind of a systematic manner, it's an acute vestibular syndrome, peripheral or central? Peripheral. Why peripheral? Because you have a unilateral nystagmus with a positive HIT, diagnosis of left vestibular neuritis, treatment is short course of steroids, and you have to reassure them. 3-4 हफ्ता लगता है, and then of course you have to do rehab. So that's very, very important. Steroid we usually use for 7 to 8 days, maybe up to 10 days and so on. So I'm not getting into this. This I think we all know. If you want to see what is the central nystagmus and the peripheral nystagmus, this from YouTube.
Component towards the left, and it increases when he looks to the left. You can see the dorsal component. When he looks to the right, it lessens, but the fast
And
component
on the right there is no
still
nystagmus. So this is peripheral or central?
towards the left.
Peripheral, central, peripheral. Because it is unilateral nystagmus, it is peripheral. And this is an animation. So this is a bidirectional nystagmus. So this is central, right? Yeah.
Component.
So how do you differentiate clinically peripheral versus central? Central vertigo patients don't have much of spinning. They have more of ataxia. They usually do not have ear symptoms, no hearing loss, tinnitus usually, but they will have other brainstem signs and symptoms like a diplopia, like a dysarthria, like a dysphagia, or maybe something on one side, and the nystagmus will be bidirectional, right? Whereas a peripheral vertigo patient will have more spinning, he will be more sick, he'll have a lot of sweating, nausea, vomiting, urge to pass motion with probably ear symptoms, but no neurological symptoms. There will be no diplopia, no dysarthria, nothing on one side of the body, and they will have a peripheral kind of a nystagmus. That is a unidirectional nystagmus. Right? Got it? Any questions? Please stop me. One important slide that I always put in any talk on dizziness is these are the deadly Ds. Any one of the deadly D you have, this has to be central. You should image the patient. So if you have vertigo with diplopia, dysarthria, dysphagia, dysphonia, dysmetria, dysesthesia means एक साइड में कुछ सुनपन आया, झंझनाहट, whatever, drop attack, कोई भी spin होके गिर गया, उसको इमेज करो, उसको इमेज जरूर करो. बोलते हैं कि पीपीपी में गिरता है ठीक है, फाइन, मीनियर में भी गिरता है, टूलो फिनोमिनस गिरता है, दैट्स फाइन, बट जिधर भी गिर गया उधर करो. Don't hesitate. You might, because I have seen vertebrobasilar TIAs where they have the superior cerebellar artery or the ICA artery, where they have a TI in the ICA territory, they'll present with spinning and fall, and you might pick up an infarct. So whenever you have a patient who falls with spins, do an MRI, right? So head impulse, I'm not getting into details. Now, this lady, I am not sure whether the video audio is there. Let's see. Okay, so it's not very audible. But anyways, so this is a 54-year-old female. She was a diabetic with history of migraine with aura. She presented with dizziness since the last 1 week. She said in her history that आंखों के सामने जिग 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 दिखता है और मुझे चक्कर आते हैं. That was her history. And on day 3, day 4, she started having headaches also. But she had a history of migraine with aura. So CT was done, CT was normal. So she went to her physician. Physician said, migraine हो रहा है, jig दिख रहा है, चक्कर आ रहा है, सर दुख रहा है. So this is migraine, and she had a history of migraine in the past. Then she had no improvement. Then she went to the ENT. Then she was referred to a psychiatrist. कि तुम्हारा सर दर्द जा नहीं रहा है, तुमको पहले से माइग्रेन है, झिक झिक दिख रहा है, हमको समझ में नहीं आ रहा तुम क्या झिक झिक दिख रहा है, ऑफ्थेल्म ने भी देख लिया, कुछ भी नहीं है. So on day 8, day 9 her headache worsened, so she was referred to us. Now look at her nystagmus. Nystagmus in this case it's a little difficult to appreciate. Just look at the sclera and look at the conjunctival vessels. Probably you will be able to pick up. So she has a left beating nystagmus. So it's unidirectional or bidirectional? Bidirectional. So it is central or peripheral? Central. Yes, absolutely. Now look at her gait. So the sister has to hold her while she is walking. I just run the video a little ahead where I am asking her to walk independently. She has to hold while she is walking. Now I'll ask her to do a tandem walk. So what's the diagnosis?
Ataxia.
No, that's fine. So
Cerebral ataxia.
correct. Yeah. So what would you do next? Okay. Do a head impulse. See her head impulse. Normal. It's a normal head impulse. She's able to focus. So whether it is central or peripheral now? Central. She has a bidirectional nystagmus with a normal head impulse test. So it is central. With a normal CT, now what would you do? MRI, correct. Yes. So we did her MRI. So that's the diagnosis. Okay, we discussed this. So whether it is an acute vestibular syndrome, peripheral center, it is central. Why central? Gaze evoked nystagmus, negative HIT, gait ataxia, and headache. So it is central. Diagnosis is mostly posterior circulation, stroke. That's her MRI. So she had cerebellar infarcts because of which she was ataxic, and she had an occipital infarct because of which she was seeing the zigzag lines in front of the eyes. You understood? Right, so it was not a migraine aura, it was basically a posterior stroke. She had a severe vertebrobasilar disease. You can see here in the angio, if you can pick up, the arrow is gone. Okay, so she had a severely attenuated right vertebral and she had a narrow basilar. So you put her on anti-platelet statin, she comes to follow up and she's doing fairly well. So it's very important to understand hints for diagnosing peripheral from central. So I think we know this hints plus is if you have hearing loss as well, always image the patient when you have a hearing loss. Now this is today morning's tricky case. So this guy, I'll not make you hear, this is just the history. He came 3 a.m. in the morning, started vomiting and started having spins since 3 a.m. in the morning. He had a history of IHD with low ejection fraction. He was on double antiplatelets and statins. No dysarthria, no double vision, and nothing on one side of the body. He had no heavy body symptoms, right? So this is just a history video. I'll skip this. Now you look at his nystagmus. Okay, you can see this? Yes. Okay, bidirectional nystagmus, right? Central or peripheral? Correct. Now you go to the next slide. Now I'm doing a hit, okay? He's able to see, right? He's able to see. Positive or negative? So now what's the diagnosis? It's a tough thing, right? You have bidirectional nystagmus with a positive hit. Acute onset. Now what? What next? So we did his MRI because he came in the emergency. The MRI was normal. So now what is the diagnosis? Huh? Vestibular neuritis. Okay. Now what will you do? Yes. So the question is, in such a case, do you give HIT importance or nystagmus importance? Always nystagmus. Wherever you have a bidirectional nystagmus, it has to be central until and unless proved otherwise. We repeated his scan in 6 hours and we got a spontomedullary. So why this happens is, whenever you have this root entry zone of the 8th nerve, that's just around the pontomedullary junction, and you have an ICA territory infarct there, it can present just like a vestibular neuritis. But the important point is you look at the nystagmus. Wherever you have a bidirectional nystagmus, forget the hit. You repeat an MRI, and the other take-home point is in posterior circulation strokes, MRI can be falsely negative up to 3 days. So wherever you have a clinical suspicion bidirectional nystagmus and a positive hit, give significant. I have burnt my hands many times. Medullary infarcts, just hit केस पे मैंने छोड़ दिया. अभी बिजी ओपीडी में एक बार देखा, एक बार मिला, एक तो टायर्ड रहते ओपीडी के बाद, लास्ट में केस आया, nystagmus यूनिडायरेक्शनल लगा, हिट किया, हिट पॉजिटिव आया, ये तो पेरिफेरल ही है. So it's not like that. Whenever you have a bidirectional nystagmus and the hit, give importance to the. So direction changing nystagmus is cerebellar brainstem. They might look like neuritis, but whenever you have a bidirectional nystagmus, the important point is you give significance to the nystagmus, not the hit. So these are the 4 common causes of acute vertigo: posterior circulation stroke, demyelination, BPPV, you all know, vestibular neuritis. I showed you all the prototype cases of which look like central or which are central. So take home message from the, I'm not over yet, right? So then take home message on 5 cases. देखो बंद करना है तो बोल देना, I'll stop. Okay, so take home message, always think of central causes. If there is no, especially if no tinnitus or deafness, watch for unprovoked vertigo lasting for minutes. जिधर भी minutes से think away from peripheral. Unsteadiness is not an ear problem usually, and look carefully at the eyes of a dizzy patient. Right. Now this 65-year-old male. Now we'll go away from brain. 65-year-old male with chakkar recently underwent CABG. Chakkar since 1 month. Cardio, neuro, ENT, psychiatrist, no relief. BP 120/80. CNS examination was normal. That's his history.
क्या तकलीफ हो रही थी अंकल?
It's very difficult to hear the audio. What he says is कि मुझे चक्कर आता है. He says चक्कर आता है. चक्कर में क्या होता है? चक्कर मुझे ऐसे चक्कर आते हैं मुझे. And चक्कर मुझे कभी आता है जब मैं बैठता हूँ या मैं खड़ा रहता हूँ. जैसे मैं लेट जाता हूँ चक्कर ठीक हो जाता है. That's the history. Correct. So he went to a cardio and his blood pressure was normal. Even the supine BP, standing BP was normal. So what would you do next? Will you do a Dixolpide? Do you do a HIT? Do you do an echo? Do you do an ECG? Do you do an MRI? His MRI was done. MRI was normal. Vertebrovascular TI, MRI was normal. BPPV नहीं है ये, because what he said is खड़ा होता तो चक्कर आता है, लेटता तो ठीक होता है. It cannot be BPPV, right? Orthostatic hypotension, sir said, is a definite possibility, and you should always check for standing blood pressure. What I did in his case, I was doing the same thing. I was checking his standing blood pressure, and the moment he stood, his pulse was gone. There is no pulse. Fortunately, just besides my clinic, I have a cardiologist, and he had come to me from the CVTS because his CABG was done, and that was his ECG. So he used to go into a pulseless AFib. So this is an arrhythmogenic synco. So the point here was that खड़े होने पे जब भी चक्कर आते हैं, they will see चक्कर ही बोलेंगे, और क्या बोलेगा? They can't say तेरे सर तो नहीं दुख रहा है, क्या हो रहा है? चक्कर आ रहा है. चक्कर अभी उनको डिटेल पूछो, ऐसे चक्कर आ रहा है, घूम रहा है. But the point here was that he said मैं जब लेटता हूँ तो मैं ठीक हो जाता हूँ. So that's very very important. Now this is a lady. She came with, she's an elderly female. Relatives history, जैसे ही लेटती है 10 दिन से चक्कर आने लगता है. 2-5 सेकंड चक्कर रहता है और फिर ठीक हो जाता है. So she went to her physician. She was given Vertin. Didn't improve with Vertin. Then she came to me. So उनको पूछा क्या हो रहा है आपको? तो मैं जैसे ही लेट तो मेरे को चक्कर आता है. अच्छा, फिर I checked her and everything was normal. No orthostatic hypotension, nothing I got. I sent for an MRI. The MRI angio was normal. Nothing was there in the MRI angio. And the symptom was this only. लेटेगी तो चक्कर आता है. Now that's her video. So I gave her. Then I said it might be a seizure. कुछ नहीं improve हो रही है. तो I gave her 1 anti-epileptic. They came the next day. बोला अभी भी चक्कर है, जैसे लेटते तो ऐसा करती है और चक्कर आ रहा है ऐसा करती है. That was her history. No loss of consciousness. अच्छा, एक और एंटी-एपिलेप्टिक दे दिया. Third day मैंने बोला था एडमिट करो. I was not wrong. I said एडमिट करो, वो नहीं एडमिट हुए. Third day they came again. That's the video. तो बोलती है आ रहा है और खत्म. That's it. Now she's normal. That's another video. आ रहा है and gone.
Is it focal seizure?
I gave 2 anti-epileptics.
Very.
Okay. Anything else? Spine. ये लेक्चर में आके स्पाइन का बात ही मत करो.
spinal injuries में I have seen.
Okay, you are talking about spinal myoclonus, proximal spinal myoclonus. Okay, so she had no history, no comorbidities. MRI was normal. Functional stress malingering या 10 days में क्यों malingering कोई करना चाहिए? No past history. So I said you get her and admit her. And when she got admitted, that's her monitor when she got the event. So she was getting syncope, which was an arrhythmogenic syncope. Her heart rate was 24. So she had a heart block. So any elderly who complains of dizziness in lying down position, you know it is not BPPV, and these are very brief paroxysmal events where they have these jerky movements. It is a convulsive syncope or a convulsive pre-syncope. So we put her on a pacemaker and she improved after that. So whenever an elderly comes to you with dizziness, look at three things: OH, arrhythmogenic syncope, and anemia of blood loss. Many of these are on antiplatelets, so they develop anemia जो मालूम नहीं पड़ता है, खड़े रहते हैं तो unsteady होते हैं. So clues in history in an elderly with dizziness is non-rotational or non-positional dizziness, dizziness on standing from bed or dizziness in sitting position, loss of consciousness, palpitations, any history of cardiac ailment, and dizziness getting better on lying down position. These are all red flags, they are not peripheral. Test that you should do in all these cases is standing blood pressure for orthostatic hypotension, CBC for anemia, ECG, echo और कुछ नहीं करा तो जरूर होल्टर लगा, जरूर होल्टर लगा, right? Now this was an elderly male, 72-year-old, dizziness since 1 week. He was a doctor's father, unable to walk without support since 1 week. He was a case of essential tremor, no other comorbidities. Received multiple anti-vertigo drugs over the past 1 week, no relief. He came with an MRI, thyroid, B12, all was normal. Now look at his video. So he has a very fine bidirectional nystagmus, very little difficult to appreciate in this video. You look at the sclera, he's got a very fine bidirectional nystagmus. Now look at his gait. It's very difficult for him to do a tandem walk, and that's his finger nose. Correct, but the MRI was normal. So what history you would want to ask? The one very important history in any dizzy patient with a normal MRI is drug history. You should always ask for drugs. He had a history of essential tremors and he was on primidone for that. Primidone belongs to the same group as phenytoin. Can phenytoin cause ataxia? Yes, very notorious. So drug history is very, very important. He was on primidone at 250 mg every day. It is exactly like phenytoin. Unfortunately, you don't have levels to check primidone. So what you have to do, it's like phenytoin and phenobarb. It's basically a barbiturate derivative. So you check barbiturate level. When you check barbiturate level, you will know कि ये भी थोड़ा high है. उसका high था. So drugs which cause ataxia are ataxia, I'm saying, phenytoin, valproate, benzodiazepines, carbamazepine, oxcarbamazepine, lacosamide, phenobarb, lithium, very notorious to cause, metronidazole, very notorious cause, and my favorite, aminoglycosides. So any TB patient comes to you, 15-20 दिन दवा चल रहा है, मेरे को कान में सीटी बज रहा है, उधर ही दवा बंद करो. इससे पहले कि वो ऐसा चालू हो जाए, उधर ही दवा बंद करो. Because it is a reversible ototoxicity. You don't stop it. Hearing तो जाएगा ही जाएगा, but ये सब चलने वाला. Already they are troubled with tuberculosis. So whenever you have a dizziness and you're not able to figure out, please check their drug. उसका लड़का बोलता है तो 20 साल से primidone ले. But the important point is, so why it happened? Okay, you should ask me, 20 साल से 20 साल में क्यों नहीं हुआ? Suddenly क्यों हुआ? All these drugs, if you know pharmacology well, there are a few drugs which have a very narrow therapeutic index. Their levels can just go from, even if you make it 100 mg ka 110 mg, वो therapeutic range के बाहर चला जाएगा. So there are drugs with very narrow therapeutic index. There are only 3-4 drugs. One is digoxin, which is a narrow therapeutic index. The other is derifylin. Third is phenytoin and all drugs like phenytoin. इसीलिए, and lithium, of course, that's very, very important. So whenever you have these drugs, please check drug levels periodically, right? So because it's very difficult to read, 20 साल से ले रहे हैं, अभी कहाँ से उसको चक्कर आ रहे हैं? And we stop the medicine, he still comes to follow his walking pretty alright. Now these are two cases which I think all of you must have seen in general practice. So this guy had a history of heaviness of both legs while walking. He wasn't overtly unsteady while walking, but he said मैं एक जगह खड़ा रहा तो मेरे को लगता है मैं गिर जाऊंगा. तो बोल रहा मेरा पैर भारी है. And when I asked him to close his eyes, he will fall. Right? Now look at the examination. Knee jerks are well elicited. Ankle jerk is absent. So what's the diagnosis?
B12.
Yes, B12.
B12.
Absolutely correct. So this is a similar video. So whenever you have an ataxic patient with a spastic gait, with absent ankle and brisk or preserved upper limb reflexes, with a positive rhomboids and an acute or subacute history, इतना ही पॉसिबिलिटी है. इसके अलावा छठा पॉसिबिलिटी है ही नहीं. B12, copper deficiency, alcohol, pyridoxine excess. People on multivitamins, particularly TB patients, they are given 100 mg of pyridoxine excess, Sjogren's and paraneoplastic. So I had published a case report in Neurology India when I was doing my MD in medicine. तभी पता नहीं था neurology करना पड़ेगा. So that was a case of copper myelopathy, presented exactly like this. B12 was normal, Sjogren's was normal. He sent his copper, and that was this guy's MRI, and he had a posterior column lesion there. So it was so these are the only few causes of sensory ataxia. So always remember to check for all these.
Sir, how much pyridoxine we should give with AKT?
With AKT 100 mg if you are on MDR, and if you are on normal 40 mg alternate, 1 mg per kg alternate days. So this is an interesting case. I thought I'll share with you very quickly. I'll go. 60-year-old female, well-controlled diabetes, numbness both feet since 3 months, dizziness since a month and a half. MRI brain, whole spine normal, B12 normal, diabetes excellent control 6.2, 6.3. Nerve conduction showed sensory motor neuropathy affecting all 4 limbs, and that was her B12 which was 631. Now you look at the way she was walking. She was admitted with us. She was a physiotherapist ka mother. And she can't walk without she holds anybody. वो छोड़ देगी तो गिर जाएगी. Now see her examination. Knee jerk is absent. Her ankle jerk was also absent. I'll show you the next video. And the most important thing was, we're looking for joint position and asking her, we are moving her toe down and up. She doesn't know ऊपर जा रहा है कि नीचे जा रहा है. She's not able to say. Then we checked her vibration, which was she was not able to appreciate vibration in both the feet. So now you go back to the previous slide that I told you. I told you 6 causes. B12, it was 631, right? Copper, it was normal. Paraneoplastic, she was a fairly healthy lady, so we didn't investigate her for paraneoplastic. She was not on any pyridoxine medications. So what was the thing that was left? Sjogren's was left. So we did her autoimmune. So that was her clinical picture. Power was normal, details were absent, vibration absent, joint position absent. She had a mild loss of pinprick up to the ankle, that could be diabetic neuropathy. But she had ataxia with a broad-based gait with a positive rhomboids. She had gone to 3 neurologists over the last 6 months, and then she came to us. Nobody checked her ANA. Her ANA was weak positive, but if you see her blood, her RO was strongly positive, and RO is for Sjogren's. So that it turned out to be a Sjogren's sensory ataxia. We gave her steroid, we gave her immunoglobulin because she didn't improve as much with steroid, and then we put her on rituximab, and that is her video now. She's able to walk independently. She's walking even much better. She's about 6 months old. So these are a few causes which are completely correctable. She can walk independently now. She goes to the market independently. So these are a few causes which are very, very correctable. This I'll skip. Uska audio अच्छा नहीं है इसलिए I'll skip this. Now this is a young male with paresthesias over the head and giddiness. Since 1 year बोलता है मेरे को सर पे मूंगी आता है 1 साल से, खांसने पे, छींकने पे, हंसने पे, और 5 महीने से मुझे चक्कर आ रहे हैं. Examination was normal. What could be the cause? MRI normal, brain normal. I'll show you the eye movements later on.
Was it the drug toxicity?
No, he was put on antidepressant later on. He was not on any medications. ये क्या बोलता है, हंसता हूँ, खांसता हूँ, चीखता, मेरे को मूंगी आता है सर में. Correct, yeah, right. So what could it be? सर पे मूंगी आता है, हंसने पे, खांसने पे. That's the point. Yes, absolutely correct. It is not psychogenic. कोई भी ये सोचेगा ना, हंस रहा है, खांस रहा है, सर पे मूंगी आ रहा है, मतलब it is non-organic. No, obviously it has to be non-organic. So now look at the eye movements. Now you will come to the diagnosis. Nobody checked the eye movement. 1 साल से चल रहा है ये. Okay, nothing much there. Now you get the nystagmus. Now I should go. Just keep looking. Keep looking. You put the eyelid up and see now. That's another video. आ रहा है and gone.
Is it focal seizure?
I gave 2 anti-epileptics.
Very.
Okay. Anything else? Spine. ये लेक्चर में आके तो स्पाइन का बात ही मत करो.
spinal injuries में
Okay, you are talking about spinal myoclonus, propriospinal myoclonus. Okay, so she had no history, no comorbidities. MRI was normal. Functional से malingering या 10 days में क्यों malingering कोई करना चाहिए? No past history. So I said you get her and admit her. And when she got admitted, that's her monitor when she got the event. So she was getting syncope, which was an arrhythmogenic syncope. Her heart rate was 24. So she had a heart block. So any elderly who complains of dizziness in lying down position, you know it is not BPPV, and these are very brief paroxysmal events where they have these jerky movements. It is a convulsive syncope or a convulsive pre-syncope. So we put her on a pacemaker and she improved after that. So whenever an elderly comes to you with dizziness, look at 3 things: OH, arrhythmogenic syncope, and anemia of blood loss. Many of these are on antiplatelets, so they develop anemia जो मालूम नहीं पड़ता है, खड़े रहते तो unsteady होते हैं. So clues in history in an elderly with dizziness is non-rotational or non-positional dizziness, dizziness on standing from bed or dizziness in sitting position, loss of consciousness, palpitations, any history of cardiac ailment, and dizziness getting better on lying down position. These are all red flags, they are not peripheral. Test that you should do in all these cases is standing blood pressure for orthostatic hypotension, CBC for anemia, ECG, echo, और कुछ नहीं करा तो जरूर होल्टर लगा, right? Now this was an elderly male, 72-year-old, dizziness since 1 week. He was a doctor's father, unable to walk without support since 1 week. He was a case of essential tremor, no other comorbidities. Received multiple anti-vertigo drugs over the past 1 week, no relief. He came with an MRI, thyroid, B12, all was normal. Now look at his video. So he has a very fine bidirectional nystagmus, very little difficult to appreciate in this video. You look at the sclera, he's got a very fine bidirectional nystagmus. Now look at his gait. It is very difficult for him to do a tandem walk, and that's his finger nose. Correct, but the MRI was normal. So what history you would want to ask? The one very important history in any dizzy patient with a normal MRI is drug history. You should always ask for drugs. He had a history of essential tremors, and he was on primidone for that. Primidone belongs to the same group as phenytoin. Can phenytoin cause ataxia? Yes, very notorious. So drug history is very, very important. He was on primidone at 250 mg every day. It is exactly like phenytoin. Unfortunately, you don't have levels to check primidone. So what you have to, it's like phenytoin and phenobarb. It's basically a barbiturate derivative. So you check barbiturate level. When you check barbiturate level, you will know कि ये भी थोड़ा high है. तो उसका high था. So drugs which cause ataxia are ataxia. I'm saying phenytoin, valproate, benzodiazepines, carbamazepine, oxcarbamazepine, lacosamide, phenobarb, lithium, very notorious to cause, metronidazole, very notorious cause, and my favorite, aminoglycosides. So any TB patient comes to you, 15-20 दिन दवा चल रहा है, मेरे को कान में सीटी बज रहा है, उधर ही दवा बंद करो. इससे पहले कि वो ऐसा ऐसा चालू हो जाए, उधर ही दवा बंद करो. Because it is a reversible ototoxicity, you don't stop it. Hearing तो जाएगा ही जाएगा, but ये सब चलने वाला. Already they are troubled with tuberculosis. So whenever you have a dizziness you're not able to figure out, please check their drug. उसका लड़का बोलता है तो 20 साल से primidone ले. But the important point is, so why it happened? Okay, you should ask me, 20 साल से 20 साल में क्यों नहीं हुआ? Suddenly क्यों हुआ? All these drugs, if you know pharmacology well, there are a few drugs which have a very narrow therapeutic index. Their levels can just go from, even if you make it 100 mg to 110 mg, वो therapeutic range के बाहर चला जाएगा. So there are drugs with very narrow therapeutic index. There are only 3-4 drugs. One is digoxin, which is a narrow therapeutic index. The other is derifylin. Third is phenytoin and all drugs like phenytoin. इसीलिए, and lithium, of course, that's very, very important. So whenever you have these drugs, please check drug levels periodically, right? So because it's very difficult to read, 20 साल से ले रहे हैं, अभी कहाँ से उसको चक्कर आ रहे हैं? And we stop the medicine, he still comes to follow, he's walking pretty alright. Now, these are two cases which I think all of you must have seen in general practice. So, this guy had a history of heaviness of both legs while walking. He wasn't overtly unsteady while walking, but he said, मैं एक जगह खड़ा रहा तो मेरे को लगता है मैं गिर जाऊँगा. वो बोल रहा मेरा पैर भारी है. And when I asked him to close his eyes, he will fall, right? Now look at the examination. Knee jerks are well elicited. Ankle jerk is absent. So what's the diagnosis?
B12.
Yes, B12. Absolutely correct. So this is a similar video. So whenever you have an ataxic patient with a spastic gait, with absent ankle and brisk or preserved upper limb reflexes, with a positive rhombox and an acute or subacute history, इतना ही possibility है. इसके अलावा छठा possibility है ही नहीं. B12, copper deficiency, alcohol, pyridoxine excess. People on multivitamins, particularly TB patients, they are given 100 mg of pyridoxine excess, Sjogren's, and paraneoplasty. So I had published a case report in Neurology India when I was doing my MD in medicine. तभी पता नहीं था neurology करना पड़ेगा. So that was a case of copper myelopathy, presented exactly like this. B12 was normal, Sjogren's was normal. He sent his copper, and that was this guy's MRI, and he had a posterior column lesion there. So it was so these are the only few causes of sensory ataxia. So always remember to check for all these.
Sir, how much pyridoxine we should give with AKT?
With AKT 100 mg if you are on MDR, and if you are on normal 40 mg alternate, 1 mg per kg alternates. So this is an interesting case. I thought I'll share with you very quickly. I'll go. 60-year-old female, well-controlled diabetes, numbness both feet since 3 months, dizziness since a month and a half, MRI brain, whole spine normal, B12 normal, diabetes excellent control 6.2, 6.3, nerve conduction showed sensory motor neuropathy affecting all 4 limbs, and that was her B12 which was 631. Now you look at the way she was walking. She was admitted with us. She was a physiotherapist ka mother. And she can't walk without she holds anybody. वो छोड़ देगी तो गिर जाएगी. Now see her examination. Knee jerk is absent. Her ankle jerk was also absent. I'll show you the next video. And the most important thing was, we're looking for joint position and asking her, we are moving her toe down and up. She doesn't know ऊपर जा रहा है कि नीचे जा रहा है. She's not able to say. Then we checked her vibration, which was, she was not able to appreciate vibration in both the feet.
Sensation आ रहा है? Sensation?
So now you go back to the previous slide that I told you. I told you 6 causes. B12, it was 631, right? Copper, it was normal. Paraneoplastic, she was a fairly healthy lady, so we didn't investigate her for paraneoplastic. She was not on any pyridoxine medications. So what was the thing that was left? Sjogren's was left. So we did her autoimmune, so that was her clinical picture. Power was normal, details were absent, vibration absent, joint position absent. She had a mild loss of pinprick up to the ankle, that could be diabetic neuropathy. But she had ataxia with a broad-based gait with a positive rhombox. She had gone to 3 neurologists over the last 6 months and then she came to us. Nobody checked her ANA. Her ANA was weak positive, but if you see her blood, her RO was strongly positive, and RO is for Sjogren's. So that it turned out to be a Sjogren's sensory ataxia. We gave her steroid, we gave her immunoglobulin because she didn't improve as much with steroid, and then we put her on rituximab, and that is her video now. She's able to walk independently. She's walking even much better. She's about 6 months old. So these are a few causes which are completely correctable. She can walk independently now. She goes to the market independently. So these are a few causes which are very correctable. This I'll skip. Uska audio अच्छा नहीं है इसलिए I'll skip this. Now this is a young male with paresthesia over the head and giddiness since 1 year. बोलता है मेरे को सर पे मूंगी आता है 1 साल से, खांसने पे, छींकने पे, हंसने पे, और 5 महीने से मुझे चक्कर आ रहे हैं. Examination was normal. What could be the cause? MRI normal, brain normal. I'll show you the eye movements later on.
Was it the drug toxicity?
No, he was put on antidepressant later on. He was not on any medications. ये क्या बोलता है? हंसता हूँ, खांसता हूँ, चीखता हूँ, मेरे को मूंगी आता है सर में. Correct, yeah, right. So what could it be? सर पे मूंगी आता है, हंसने पे, खांसने पे. That's the point. Yes, absolutely correct. It is not psychogenic. कोई भी ये सोचेगा ना हंस रहा है, खांसने को सर पे मूंगी आ रहा है मतलब it is non-organic. No, obviously it has to be non-organic. So now look at the eye movements. Now you'll come to the diagnosis. Nobody checked the eye movement. 1 साल से चल रहा है ये. Okay, nothing much there. Now you get the nystagmus. Now I should go. Just keep looking. Keep looking. You put the eyelid up and see now. It's a. क्या नहीं किया? ये एक ही कंडीशन है जिसमें वर्टिगो में स्पाइन करना चाहिए. CV junction. So he had a CV junction anomaly. Partner kiya hai. So the point was, why was he having paresthesias on laughing, sneezing, coughing? As madam said, Valsalva में ये सब जो posterior fossa structures है ये नीचे जाता है और वो foramen magnum already crowded है. I hope you understand what is CV junction anomaly, right? This is your cerebellum and that's your brainstem. Okay. ये इधर खत्म हो जाना चाहिए, इधर खत्म हो जाना चाहिए, ये इसके नीचे जा रहा है, it's going down, right? So what happens, and that is where your trigeminal nerve which supplies the face and the head. Your face and head supplies by the trigeminal nerve. So when they cough, sneeze, laugh, the CV junction comes down more, and the trigeminal nerves get stretched, so they get paresthesis over the head. That was the thing, and nobody checked for his nystagmus. That was the problem. So the moral of the story is, upbeat, downbeat, vertical nystagmus, वापस MRI करो, और ये एक ही condition है जिसमें CV junction करना ही चाहिए. That's the only place where I say that you do cervical spine or you do a CV. Otherwise, cervical division is a rubbish thing. Cervical spine को जो X-ray करके आते हैं उसको कचरे में डब्बे में डाल देंगे, होता ही नहीं. Okay, this is something similar. Okay, now this is a young woman. One more case.
Yeah,
कोई सो नहीं रहा है?
नहीं
Okay, one more case. Young woman with Bell's palsy since 1 year. Okay, she came to us with Bell's palsy since 1 year. Look at her video. She has a facial, you can see that? She got a facial, right? On the left side, she has a facial. So she got a nystagmus. Which is higher frequency, which is lower frequency? ये higher frequency है बराबर? Sorry, higher amplitude and this is higher frequency. Okay, what is this nystagmus called? This is diagnostic nystagmus. ये diagnosis मालूम पड़ जाएगा, MRI करने की जरूरत नहीं. So Bell's palsy था, Bell's palsy recover नहीं हुआ 1 साल में. So she came here, right? Was this Bell's palsy in the first place? It wasn't, because she had a bidirectional nystagmus. Whenever you have a high amplitude nystagmus on one side and a higher frequency nystagmus on the other side, this is called as a Bruns nystagmus, and it is diagnostic of a CP angle. This is the CP angle tumor. Bell's palsy में अपन MRI करते हैं क्या कभी? कभी नहीं करते. तो ऐसे केस में करना चाहिए. तो Bell's palsy में हमेशा ये देखना चाहिए. सिर्फ फेस का asymmetry नहीं देखना चाहिए. And of course, she had developed hearing loss over time. Now, this is another guy. The audio is not there, unfortunately. I'll tell you his history. This guy said that I've been having this chakkar since the last 1 year. और मैं गर्दन हिलाता हूँ तो ही मेरे को चक्कर आता है. मैं गर्दन हिलाता हूँ तो ही चक्कर आता है. इधर देखता हूँ तो ही मुझे चक्कर आता है. ले एक साल तूने क्या किया? बोला मैंने MRI किया, MRI नॉर्मल है, ENT को दिखाया, नॉर्मल है. तो बोले चक्कर में क्या होता है? बोलते मैं चक्कर आता है, जैसे ही गर्दन इधर करता हूँ मेरे को लगता है कि मेरे को थोड़ा चक्कर है. चक्कर में स्पिन नहीं होता है, लेकिन मुझे ऐसा लगता है मेरे आँख के सामने अंधेरा आ रहा है. तो बोला अच्छा, फिर आई चेक, आई गॉट नथिंग. तो बोला मैं एक काम करता हूँ, मेरे को जब भी आएगा मैं आपको वीडियो लेके दिखाऊंगा. This he did at home. He's taking a selfie and he's turning to one side to replicate his chakkar. आ गया उसको चक्कर है. गया. He's almost falling. अभी ठीक हो गया. That's his history. What is this? हाँ? हाँ? Kind of, yes. Kind of. What else? You can refine it a little more. This is something which is called as. जब भी मैं राइट में टर्न करता हूँ तभी मुझे चक्कर चालू होता है. ये क्या बोलेगा? कोई भी सुन के क्या बोलेगा? क्या है? BPPV है, करेक्ट? राइट.
मायोपैथी.
This is called as Bow-Hunter syndrome. That is basically because of vertebrobasilar artery disease. So this guy, we did his DSA. He had a very thin vertebral artery. So he was looking on one side. Already whatever thin है, वो तुम्हारा इसमें cervical spine में जो foramen रहता है उसमें और compress हो जाता है. So it's like a dynamic compression, and you get a spin. So never ignore this. We didn't do stenting because it was a dynamic compression. We just put him on a single antiplatelet and told him, ये मत कर आगे से. Don't do this. It is stupid. If he does it, he might get a stroke. For 1 year, he was struggling. And on the contrary, if you do maneuvers in him, what will happen? Crash हो जाएगा सीधा. तुम्हारा बेड पे ही तुम्हारा practice बंद हो जाएगा वहाँ. Right. So these are all the cases. Central vertigo, more ataxia, less spinning, deadly D's. Always remember, direction changing nystagmus is central. HIT negative होना चाहिए central में, but कभी-कभी false positive रहता है. Heavy body symptoms ignore मत करो. MRI negative हो सकता है initially. And my favorite slide, patient comes to us with dizziness, we take them for a ride. How? क्या हो रहा है? चक्कर आ रहा है. सब देखा, ऊपर से नीचे तक देखा. एक काम करेंगे, एक्सरे करके आ, सर्वाइकल स्पाइन का. एक्सरे लाके दिखाया. सबका अपन इधर जितने लोग बैठे हैं सबका एक्सरे में स्पॉन्डिलोसिस दिखने वाला है. जितने भी लोग बैठे दिखने वाले हैं. नहीं दिखेगा तो रेडियोलॉजिस्ट देगा क्योंकि उसने इतना पैसा लेके एक्सरे किया है. तो अपन देखेंगे. अच्छा, घंटा समझ में आता है एक्सरे. मेरे को तो नहीं समझ में आता है एक्सरे की स्पॉन्डिलोसिस है कि नहीं. घंटा किसी को समझ में आता है यहाँ पे. ऑस्टियोफाइट को कभी दिखा नहीं लाइफ में, पर दिया तो अरे मैंने बोला तेरे को स्पॉन्डिलोसिस है, तेरे को चक्कर आ रहे हैं. लेकिन गलती से तुम्हारा रेडियोलॉजिस्ट फ्रेंड नहीं है, उसने नॉर्मल दे दिया, तब क्या करोगे? तेरा बीपी कितना है? एक लेडी है, एक 18 ईयर लड़की अगर आती है उसका बीपी 80 90 60 है, अरे लो बीपी लो बीपी लो बीपी, पानी पी पानी पी पानी पी। और किसी का 150/90, अरे नहीं तेरे को बोला तेरा बीपी इतना हाई है, उसको कम कर, इससे तेरे को चक्कर आ रहा है। अगर बीपी में नॉर्मल आया फिर तुम बोलोगे यार तुम्हारा उम्र कितना है, तो मेरी 70 है, शायद ब्रेन में ब्लड कम पहुंच गया इसलिए चक्कर है। और अगर यंग आदमी रहेगा, कान में नहीं पानी रहता है, वो पानी में कुछ इम्बैलेंस है इसलिए आपको चक्कर आ रहा है। तो पेशेंट अल्टीमेटली पूछे ब्रो मेरे को है क्या, तुमको वर्टिगो की बीमारी है। फिर हमारे पास आते हैं, फिर हम लोग पूछते हैं क्या हुआ, मेरे को वर्टिगो है। मेरे को बीमारी क्या है, मालूम है कि बीमारी क्या है? नहीं मेरे को वर्टिगो का बीमारी है, वर्टिगो क्यों हो रहा है और मेरे मनके में गैप है। थैंक यू वेरी मच, दैट्स माय टाइम। आई होप यू एंजॉय। एनी क्वेश्चंस प्लीज आस्क। And he had no relief. This was his history.
क्या तकलीफ हो रही थी?
खाने के टाइम चक्कर आते हैं, यही हिस्ट्री है उसका, इतना ही हिस्ट्री है। द पॉइंट दैट ही सेड वाज जैसे ही मैं खाना खाता हूँ मुझे चक्कर आते हैं और ऐसा हो जाता हूँ, बस इतना ही हिस्ट्री है। और 3 एंटीएपिलेटिव ऑलरेडी चल रहा है and he continues to have this. So why is it not vertigo? Because it is so situation specific. Only when he is eating he is getting this. And the fact that last what he says is चक्कर आते हैं, उसमें ये हिस्ट्री थोड़ा बार पूछने के बाद वो बोला कि चक्कर आने के बाद मैं थोड़ा ऐसा हो जाता हूँ। So he had a versive head deviation to one side with the chakkar and only while eating. That is called basically as reflex epilepsy or an eating form of epilepsy. So chakkar can be a manifestation of seizure. I have a few patients who have tinnitus, loud tinnitus, and they just become unaware for a few seconds and they become normal. So this is basically extratemporal, not mesotemporal, the lateral temporal lobe epilepsy. So in that case, usually the symptoms are preceded by some auditory phenomena like a tinnitus, and then they will lose awareness. In vertigo, you will never lose awareness.
Nephrometry, ELSA techniques, HPLC based heavy metal analysis and laboratory medicines. I hand over the stage to Apeksha.
First of all, vertigo is a sensation of spinning, movement or dizziness where no actual movement is occurring. It is a symptom that may result from disorders affecting the inner ear, brain or the body systems. The key points: a sensation of spinning or movement. Patients may feel that they or their surroundings are rotating or moving. You have peripheral vertigo, that is basically due to the inner ear and the vestibular system abnormality, and the central vertigo that results from disorders from brain and the central nervous system. Laboratory tests help to identify systemic causes. Blood tests can detect conditions such as anemia, infection, inflammation or metabolic disorders that can contribute to dizziness and vertigo. So the take-home message is vertigo is a symptom and not a disease. Identifying its underlying cause is essential for accurate diagnosis and effective treatment. To make it a little more interactive, I would just like to have a few cases. So I would need the help of the audience to help me reach the diagnosis. This is starting from case number 1. This is a 38-year-old female with acute onset vertigo for 5 days, accompanied with nausea and imbalance. She reported a recent upper respiratory tract infection 2 weeks earlier. There is no history of trauma or vascular risk. She also has complaints of ear pain, query, hearing loss. So the blood investigations. In the CBC, we have total leukocyte count 15,800 was the WBC. The hemoglobin was 9.8. The platelet count was 1,20,000, which was low. The ESR and CRP were raised. ESR was 40, the CRP was 18, and the ANA and the RF was negative. Then in terms of viral serology, it was consistent with recent viral infection. Herpes zoster IgM came out to be positive. So, what would be any diagnosis from the audience? Anyone?
Vestibular neuritis.
Yes, sir, most likely. So, I had a few DDs. So, first would be vestibular neuritis, but as you said, it is post-viral vestibular nerve inflammation, but it usually comes without any hearing loss. Yeah. Then my first diagnosis would be viral labyrinthitis, because if there was a recent URTI, there was positive viral serology and vertigo with hearing loss. Then other DDs could be autoimmune inner ear disease, but it was less likely because the ANA and RF was negative. Systemic inflammatory disease, but there were any lack of any systemic manifestations in this case. So, the role of pathology in diagnosis. The CBC identified leukocytosis in this case. ESR and CRP demonstrated active inflammation. Viral serology confirmed recent herpes zoster infection. Autoimmune markers help to exclude the autoimmune cases. The take-home message would be, lab investigations play a crucial role in differentiating viral labyrinthitis from autoimmune and vestibular disorders, leading to the identification of post-viral inflammatory etiology of vertigo. So, this was a case of acute viral pruritus secondary to viral herpes zoster. Now, just a little bit about CBC. CBC is a routine blood test that we all know. It helps to evaluate overall health and identify systemic conditions that may contribute to dizziness or vertigo. It helps to detect anemia. It is because of low hemoglobin or RBC cells can reduce oxygen delivery to the brain, therefore causing dizziness and vertigo. It detects infection. Elevated WBC counts may indicate an underlying infection that can affect a lack of well-being as well as balance. It also helps to evaluate inflammatory conditions. Changes in WBC count can suggest inflammation or other systemic disorders associated with dizziness. So the take-home message would be, CBC is a valuable screening test for detecting anemia, infection, inflammation in patients persisting with dizziness or vertigo. Nonetheless, ESR and CRP, which we all know are inflammatory markers, they help us to detect inflammation, they help us to identify infections, inflammatory conditions as well as systemic illness. Basically, it helps to rule out autoimmune as well as vasculitis disorders, just in case if there are increased levels. So they take us to a diagnosis towards vasculitis and other blood vessel diseases. So, the take-home message would be ESR and CRP are useful screening tests for detecting inflammation and identifying autoimmune or vasculitis disorders that may contribute to dizziness and balance disturbances. This is case number 2. He is a 15-year-old male patient with vertigo, diplopia and nausea since 10 to 15 days. The blood counts were hemoglobin 11, WBC count 5,800, platelet count 1,85,000. The HbA1c was normal 5.0, fasting blood sugar was 90, thyroid was normal 3.3. Also, in this case, since all of this was normal, we did a renal function test. The serum creatinine was 0.9. Serum electrolyte, sodium levels were 116, they were low. Potassium was normal, 3.96, chloride was 99.2. Again, the doctor advised to do a repeat sodium. We got again a low reading. The doctor was not convinced, still we gave him one more sodium level, which was low. Then the doctor advised, we helped the doctor to do a urine sodium or a osmolality, just to check that was there anything that we are missing out. That again was found to be low. The urine osmolality was low as well as urine sodium was low. The doctor went to the extent to ask the father whether was the child taking any medicine or was he taking any drugs. So a urine drug of abuse panel was done where all the 9 markers, where all the 9 tests were negative. But to his surprise, he was taking a medicine called as oxcarbamazepine. The child had seizures, because of which he had low sodium levels. The dose, which I think it was just 15 days that he was taking the dose, it was maybe 3 times a day. Was it an overdose? We don't know. So, the differential diagnosis would be oxcarbamazepine induced hyponatremia. So, the positive findings would be there was a history of seizure disorder, recent use of oxcarbamazepine, severe hyponatremia, and it was a known adverse effect of oxcarbamazepine through SIADH. So the diagnosis was oxcarbamazepine induced hyponatremia. Electrolyte helps to measure the minerals in the blood, as also necessary for proper nerve functioning, muscle activity, fluid balance and coordination. Serum sodium, if abnormal, we leads to dizziness, confusion and neurological symptoms. Serum potassium is important for muscle and nerve function. Imbalances can lead to weakness and lightheadedness. Calcium is also essential for nerve signaling and muscle contraction. Abnormal levels can affect balance and coordination. Magnesium plays an important role in nerve and muscle function. Deficiency may contribute to dizziness and vertigo. So, serum electrolytes helps us to identify metabolic disturbances like dizziness, vertigo, weakness and balance disturbances. Coming to case number 3, he is a 62-year-old male with recurrent episodes of vertigo lasting for 10 to 15 minutes a month. He reported occasional unsteadiness while walking and had a history of hypertension and smoking. Also complains of polyuria with no hearing loss, tinnitus or ear pain. His BP was 150/95, that seems to be high. The fasting blood sugar is 240, HbA1c 7.4, which is high. LDL cholesterol 165, again that is high. Triglyceride 220, again that is high. But the remaining tests like CBC, renal functional test, PT, APTT, INR was normal. The lupus anticoagulant, anti-cardiolipin antibodies, anti-beta-1 glycoprotein 1, considering his age, was negative. ANA, ANCA was again negative. Homocysteine levels were normal. CRP and ESR was within normal limit. So, any guesses what would this case be? Diabetes, yes, but
Leukotoxicity.
Leukotoxicity. Okay, anyone else? In this case, it was vertebrobasilar transient ischemic attack. The whole idea was because there were recurrent episodes lasting for few minutes, gait unsteadiness, there was underlying disease like hypertension, diabetes, smoking, dyslipidemia.
High LDL.
Yes, high LDL. So that was a transient ischemic attack. So that's why. The pathophysiology was atherosclerotic narrowing of vertebral or basilar arteries causes transient ischemia of the brainstem, cerebellum and vestibular pathways resulting in episodic vertigo. So this was the diagnosis. The vertebrobasilar insufficiency or the posterior circulation transient ischemic attack with underlying combination which was hypertension, smoking, diabetes and dyslipidemia. So we all know that blood glucose and HbA1c assesses the levels of blood sugars and identifies diabetes or glucose abnormalities. The key functions are hypoglycemia causes dizziness. So low blood sugar can lead to dizziness, lightheadedness, weakness, sweating and confusion. It helps to identify diabetes, elevated blood sugar and HbA1c, which indicates poor blood sugar control and diabetes mellitus. We also have diabetes related neuropathy and vascular disease, but that occur in long-term diabetes, can damage nerves and blood vessels affecting balance, circulation and overall neurological function. So the clinical significance evaluating blood glucose and HbA1c helps us to determine whether dizziness is related to blood sugar fluctuations or it is a complication of diabetes. So the take-home message is blood glucose and HbA1c testing are important for detecting diabetes and detecting metabolic causes of dizziness and vertigo. Nonetheless, lipid profile we all know is important to help to assess whether the cholesterol, triglyceride levels providing valuable information for cardiovascular health, stroke as well as dizziness or vertigo. The clinical significance of lipid profile would be it helps to evaluate the risk factor of atherosclerosis or vascular disease, helps identify conditions that may impair blood circulation to the brain, and it supports stroke risk assessment, especially in patients with central vertigo or neurological symptoms. Take-home message would be lipid profile helps to assess cholesterol, triglyceride levels, providing valuable information about cardiovascular health and stroke risk in patients with dizziness or vertigo. Coming to case 4, the 51-year-old male with vertigo for 3 weeks, tingling numbness in both feet, difficulty in maintaining balance by walking, no history of any hearing loss, no ear discharge, no history of trauma or any seizure. Dietary history revealed poor nutritional intake, chronic alcoholic investigation, chronic alcoholism. So the lab investigation, he had CBC which was 10.2. The WBC count was 5,600, platelet count was 1,50,000. The MCV, The RBC indices was 101.2. The peripheral blood smear shows macrocytic RBC with hypersegmented neutrophils. The B12 levels were low, 154. Vitamin B1 levels were 17.8. Thyroid, renal and electrolyte tests were normal. Any guesses? The B1 levels were low. It was done on an HPLC method at Agilis Diagnostic. It was 17.8. Any diagnosis?
Alcoholic.
Yes, so alcoholic. So what would this case be? I'm giving you a hint. B12 was low, B1 was low.
What mix and
Pardon?
what mix?
More or less you're right. It is B12 related deficiency in neuropathy as well as Wernicke's also B1 deficiency. So,
Recognizing, investigating and managing the dizzy patient. This is designed as a practical pocket guide. You can see the size of the book also. It is something that you can carry. So this is an invaluable source, built for healthcare professionals of all specialities to carry and consult easily on the go. So to officially launch this book, it is a distinct honor to invite Mr. Anjani Prasad and Mrs. Neelam Prasad to do the honors. Just to give a brief introduction, Mr. Prasad is the Managing Director of Arcoma India Private Limited, which covers a couple of other countries including India. Mr. Prasad is the owner of Article Diagnostics and Polyclinic and also Radiance chain of salons. Most importantly, Mr. and Mrs. Prasad, they are Dr. Neha's parents. They have been the ultimate source of inspiration, motivation and encouragement behind her journey. So please join me in welcoming them to the stage to launch the book.
So I would also like to call upon Harsha Aunty and Deep and Rajesh Shankar for, since they are the publishers, we all know them in the name of National Book House and Bharani. So they are here along with my parents. Yeah.
Can I?
Yes.
And I'm very happy that she chose the day today, and we are all proud of it for all her achievements, and I wish her to really grow more and more, and with the support of all of you who have been here. Thank you very much.
2 minutes of your time to why this book was written and what made the book through and through. Then we are pretty much changed, like I mentioned in the morning. Point A से point E जाने में time नहीं लगेगा. Because time, patience, finances, underdiagnosis, multiple, all has taken time over the patient and toll over the patient. So the heavier the weight, it is heavier the weight than it appears. It is more than what even patient can even express. Sometimes they become emotionless. Okay, a debilitating condition, loss of morale, and too often underdiagnosed. Many symptoms and partially open doors, but going nowhere. That's my line, because it is going nowhere, it's not taking you anywhere, it's just going to that same extra pyramidal symptoms and the things, just go about and visit to multiple specialty and machine dependent, high cost diagnosis. The knowledge was always there, the roadmap didn't, means the vestibular science was always there, only it was scattered. And multiple zones, they never bought a single control. Now I come from an academician background. Basically, if you have heard article, that's my grandparents' name. My Nanaji was a principal basically. And we are from North, and we come from that education background, from where teaching, learning and earning is one thing, and carrying the legacy and giving it to someone else is secondary. So my dream was always to become a doctor, and I became that. But it was also good to be there should be an excellence. Par excellence is also important. Everything is not money, at the end of the day, when we came empty-handed, we'll go empty-handed. But one thing will always remain: your own self-confidence and your knowledge that nobody can take away from you. So this was one thing which my mom has critically taught me along with my dad, that is resilience. And today they have come here specially for this. So there was the only question that kept lingering in my mind in my entire practice is 2017 when I finished my MS in ENT. It's been 9 years that every day I'm with vertigo patients. That why are we not having a clear-cut practical guide? So I went ahead to write out because I heard a lot of, there are many senior doctors in India, but somehow the other way they're just marketing something which is not actually required, you know. We are Indians, we are known to be a clinician, we're good, strong clinician doctors in India, and we should be very good at our skills, as we have seen from the morning in the sessions. So then we went out and wrote a clinical book wherein there is a history, red flag, hence evidence-based bedside clinics, targeted examination, vestibular rehab, and it is a dream come true to have this book. I would like to thank Clever Pen Publishers who are here to support the journey along with Pitchman Labs who have helped me to get the content and the references. Thank you so much. So this is a new angle to the vertigo, and the book should be anyways in next 10 days max or 10 to 2 weeks max. Those who wish to register, there is a scanner code, they can scan and have a registration on the Google form. And we are open for feedback when the books are out. Thank you so much. The lunch is now open. Please proceed towards the cafe. From straight here, 10-15 steps, and you can proceed there. I divide vertigo into central, peripheral, systemic, psychogenic, autoimmune, and drug-induced conditions. Central is brain, spine, foot. Peripheral is eyes and ears. Systemic is anemia, thyroid, diabetes, and blood pressure, of course. Psychogenic will be a number of spectrum of disorder which already Dr. Suresh has covered in the morning. Autoimmune condition we saw about SLE, we saw about Sjogren's, we saw about MS. And drug-induced condition we have already enlisted the number of drugs that can be a possible cause, even along with metal toxicity now. So basically all which are anti-convulsion, anti-epileptics, they stand by here. Okay? Management. So management is generally reassurance, canalic repositioning maneuvers, rehab, pharmacotherapy, and rarely surgery. So pharmacotherapy. Now why do we give it? We are not saying that we have to not give it, we have to give it. But there are some restrictions and some limitations for all this. So it is given to reduce the sense of motion, it is to relieve the neurovegetative symptoms, it is there to reduce the anxiety and enhance the process of vestibular compensation. Now coming to this point, I would like to tell you something is, what do you mean by compensation? There are some statements that we need to understand. One is unstabilized, stabilized, uncompensated, compensated. अरे अंकुश जी अपना व्हाइट बोर्ड है अपने पास लिखने को? हाँ तो वो अभी रख दो, नहीं नहीं जी बाद में देखेंगे. हाँ, so you have to understand that what does it mean? When a person gets an acute vertigo, he is highly unstabilized. The medicines are the first treatment to stabilize the patient. But the longevity of the disease or the continuity of the suppression will lead to uncompensated vertigo. So unless and until it becomes compensated, the vertigo, the patient will not go back to the normal phase. Understood? So this four terminologies has to be understood: unstabilized, stabilized, uncompensated, compensated. So this we'll be discussing further when we go in the rehab and reversion, but here you have to listen to this. Now in the vertigo we have only 3 types of drugs. Vestibular suppressants we have antihistaminic, anticholinergic, CCBs and benzodiazepine. Histamine antagonistic is beta histine and neuroprotective is nootropics. So basically there is this, I am starting with Meclizine. Meclizine is very rarely used in our prescriptions, okay, and it is one of the good drugs, because it's commonly used in female, especially in case of pregnancy. It is safe to be given in pregnancy, make a note of it, but less are used in the Indian scenario. So it has an anticholinergic activity, it prevents motion sickness, it reduces the severity of the symptoms, it has the depressive CNS activity, and hence it should not be given extensively, it should be given only in the acute phase because it can hamper the compensatory mechanism. Next comes your calcium channel blocker, Cinnarizine. So what is the Cinnarizine does? Cinnarizine inhibits the flow of calcium from the endolymph into the cells of crista ampullaris. Cinnarizine enhances the microcirculation in the inner ear. Flunarizine is the other drug from the same family which works as an anti-migraine. You use it as an anti-migraine prophylaxis. You start it at 5 and give it till 10 milligram. Both are very powerful average suppression action, but the only side effect they will have is again affecting the central compensation, weight gain, depression and sedation. Now one more take home message in this. Very commonly used calcium channel blocker in an hypertension is correct. So if you pick up a drug which is from the same group, what is the first side effect you are expecting? Correct, ma'am, absolutely correct. So this patient with an extended Cinnarizine and take will have a pedal edema. That pedal edema itself will give you a loss of proprioceptions, when they start walking because of the swelling in the leg. So always remember, when you are picking a drug of an anticortical, should not be from the same family. Clear? So if you are giving a BP medicine which is already from a calcium, like nowadays this cilnidipine and amlodipine, the amlodipine has been a long list. So don't use Cinnarizine from that family. That is I would recommend. Pick up some other class, some other group. Next comes is benzodiazepines. Now benzodiazepine has a high efficacy, high potency, high therapeutic index. So there is nothing to worry about that drug. Safety margin is very high. So they are given just to allay the anxiety, reduce the anxiety of this patient. They are centrally to potentiate GABA, useful for management of vertigo in lower doses. They, in addition to vestibular sedation, can exhibit anxiolytic property, inhibit vestibular compensation, sedation, addiction, impaired memory, increased risk of falling and impaired vestibular compensation. That means it should be avoided in elderly population. Even though people they take sleeping pills like Alprax, very commonly given. But you must understand that the more you give it, the more the chances of fall may having. Because first is they are already having pressed vestibulopathy, means they have a reduced balance function after the age of 40. Then further giving this for a very long time can further deteriorate the function to try to wane them off from that drug, rather than continue to the other possible option that I use is etizolone, because etizolone is most likely to give a lesser, etizolone is short half-life, only 8 hours in the body and it goes off. So the more you have to reduce the suppression, from the patient, and they should be more alert. The more they are alert, the more better vertigo, the rehab will happen in such cases. Now the next is prochlorperazine, very commonly used by everyone. So again, it's one of the top molecules that are used, for the drug. It is only available in the injectable forms also, and it has to be used again for a very short time, and external symptoms, hypotension and anticholinergic activity. Again, it will block the dopamine receptors. So all the suppression that we spoke about meclizine, Cinnarizine and prochlorperazine, these drugs can cause extrapyramidal symptoms and also Parkinson's. We have seen such cases. The patient will have a BPPP, and when you make them stand on rhombus, they will have a postural instability. They will have tremors. They will have bradykinesia. So these things will be predominant if you give them more than 5 days. So ideally, prescribing this buffet of drugs should not be more than 3 to 5 days, and pick up only one drug out of it. So that is the right way of doing it, rather than giving everything. So next comes beta-histine. Everybody knows about about this drug. So beta-histine is the only non-sedating anti. So I prefer this among the geriatric population because safer option. It is not interacting with any of the drugs, so can be given. The research paper says going up to 144 milligram, but I find it even a very good desired result on 24 milligram. So why increase the dosage? Okay. It increases the circulation to the inner ear and increases the vestibular function through the activity on the H3 receptors. It is known to there are many papers which has been published which show that it helps in compensation. So it's an H3 inverse agonist. Okay. Now coming to nootropic agents. The nootropic agents includes the one which improves the cognition of the patient. Piracetam, ginkgo biloba, very commonly used by neurologists post head injury, post stroke. It has an antioxidant property. It increases the microcirculation and helps in cognition. So these are the few drugs which I wanted to list you about the pharmacotherapy part. If you have any questions, please, I am open for this based on this topic.
Difference between Meclizine and prochlorperazine?
Very similar to each other, sir. There's not much of a difference. They belong to the same anti-vomiting drug combination. But if you go to see, the Meclizine has a very drastic effect on the blood pressure that I have seen in the patients. So I would still rate prochlorperazine over Meclizine if there's a patient with low BP. Not much of a difference, but and again Meclizine is safer in pregnancy. There are results. So likewise, so I would prefer Meclizine over, but it's very less used in India comparatively to the other three. So you can always think over that drug.
And dose of beta-histine?
See, beta-histine now there are n number of articles being written.
Indian context.
See now this is a very something which is very, for me even 8 milligram is effective. So in my BPPV cases, if they have a fear in their mind, I would like to prescribe 8 milligram 3 times a day for 3 days and taper it off in 7 days time. Or if there is someone who is already pre-existingly on the other combinations like prochlorperazine and sinazine diamine hydride, I will stop those, shift them to beta-histine, stop beta-histine, re-evaluate for BPPV and then come to the final conclusion to rehab. That is how I will manage the case. Even in cases of menias, I have found profound results at 60 milligram OD and 24 milligram OD. We have got good results. Because again, when you deal menias, it's going to be menial migraine spectrum. And menias mein to uska to acha खासा result hai, everybody knows that. So there is no problem with beta-histine at the age groups. Very safer as compared to the others. Especially in geriatrics, I would recommend strongly.
Thank you.
Any further questions?
So in nutshell, out of sinazine and beta-histine, which one do you
Ma'am, it is not a nutshell, it is about which syndrome and what are you taking care of. Like in acute vestibular neuritis, this 3 will work. And maybe beta-histine will have to work on a very higher dosage. For example, sinazine diamine hydride combination or maybe prochlorperazine will have a more better result, or beta-histine you will have to give it a higher dose, say 48 milligram. But then after 3 days you have to stop only, so you can pick up any one, but there is something known as dose dependent action in case of vestibular neuritis. Now again when you come to BPPV is safer to have beta-histine. Why? Because the other 3 will suppress your nystagmus and you will not get positional vertigo. Venous disease you cannot give in a prophylactic doses to beta-histine. You will have side effects because of the 3 to 5 days wala contention of the suppressor, and actually beta-histine becomes an option. So which diagnosis supports what? That is the main take home. Questions? No questions? See, even I have explained well. Yeah. As Dinesh Singh mentioned, how many will have cervical spondylosis? Huh? Correct, absolutely right. But how many of them will have BPPV? So the word itself says benign paroxysmal. Benign मतलब क्या? खुद से रुकने वाला. Paroxysmal मतलब sudden episodes. Positional मतलब when you change the head movements, and then comes the vertigo. Okay? So सवाल में ही जवाब है. So what is benign paroxysmal positional vertigo? It is the commonest form of peripheral vertigo. It is a mechanical failure, but of which organ? Right answer gets a 5 star. BPPV is a mechanical failure of which inner ear organ?
Semicircular canal.
No. Wrong. Yes, the answer देखो मिल गया. The answer is utricle, because what happens is there are layers inside the utricle which carries those crystals. So when that layers detaches, at that time the crystals spread. So there are theory of biomineralization, demineralization theory, which is because of the calcium metabolism or the vitamin D deficiency getting affected, and that is why you get BPPV attacks. And it keeps on circulating in the canals. Okay? So if I take out the skull, now this skull has so many faces, right? कितने लोगों का face बनता है in the entire universe. Imagine the same inner ear will be also taking this kind of measurements. ना तो किसी का crystal फंसेगा, किसका नहीं फंसेगा. So this disease may be self-limiting, and some may get it stuck. So even the size dimension of your canals are different in every different individual. Even it is placed in temporal bone, but the sizing may differ. So that is why some may not. And the size of the utricle will also differ, na? How much calcium is there? See, we do DEXA scanning to know the calcium in our bones. We don't have any machine to know where our this is going. Only we have some tests, lab tests. Even if it comes normal, the subclinical levels, we don't know what's happening. So that is the case with BPPV, and that is why this happens. Okay. What is the commonest canal? Posterior canal is the commonly affected. The right hand side is the commonly affected, followed by horizontal canal, followed by the anterior canal. The cause still remains idiopathic, but the researchers are saying what I have told you right now. So what is happening? So today in the morning I had mentioned about the yaw, pitch and roll. So X, Y, Z. So what is the semicircular canals? They are the sensors to the ears. So these sensors, what they do? They tell you where you have to move your head based on the images which are getting created in the fovea. And that is how the brain intercepts everything. So basically these otoconias, they get dislodged because of the calcium metabolism getting affected, and they enter one of the canals giving you this vertigo. If it is free floating in the endolymph, it is canalithiasis. If it is getting stuck to the cupula, it is cupulolithiasis. Cupulolithiasis gives you atypical variants of BPPV. Canalithiasis gives you normal variants of BPPV and easy to treat. Secondary causes I mentioned: vitamin D, post head injury, post trauma, post prolonged bed rest, post surgeries, post any kind of inner ear infection, and age related. One take home message again: any case of patient coming with an history of RTA or a head injury, please don't be very fast to label them as BPPV. There is one more symptom which is known as labyrinthine concussion. Now what is labyrinthine concussion? That's an immediate differential diagnosis to BPPV. Labyrinthine concussion is an injury to the membranous labyrinth, means your audiogram, your HRCT temporal bone, your MRI, everything will be normal. But that layer which is inside the bony labyrinth will get hit, and there will be suddenly a drop in the mitochondrial activity which will lead to the depletions of the metabolic content, and that will give rise to vertigo. Okay. So there is a difference in that. In labyrinthine concussion generally we give rehab. BPPV is entirely maneuver. Okay. Keep it in mind, you may never know that a patient has come with 10 times maneuver not getting fine. And actually it doesn't require only, and he will have a multi-canal involvement. So just keep this in mind. So now what are the symptoms? So there are sudden episodes, there will be rotatory spinning, there will be head movements, there will be nausea, vomiting, and it will be from seconds to minute, and there may be anxiety in that patient. The first episodes are always longer as compared to the coming episodes. They will be shorter because first time the crystal also takes a longer part in the diameter to move. Okay, so that is why the longevity is there in that first episode. It will be for the entire say 12 hours ka bolega patient. But keep it in mind that the nausea and vomiting will not be that much as compared to the patient in neuritis and even in migraine. So just keep this in mind. Now what is Evol's law? Evol's law is followed in BPPV. Alexander's law is followed in neuritis. Here we are talking about Evol's law. So eye movements occur in the plane of canal stimulated. For example, if I am checking the patient on right-sided disc sulci, I should be getting the right-sided torsion upbeat. I should not do ulta. Ulta becomes agiotropic or atypical. Okay. Excitation of canal creates a stronger response than inhibition, and there is an amperopetal. The flow is towards the stronger response than horizontal canal. That is why there is always a confusion between apogeotropic, geotropic, and horizontal canal, and that is not the case in case of the vertical canals. That is posterior and anterior canal. So the diagnosis is by disc sulci, supine roll, and deep head hanging. So now I will demonstrate the three. Who is coming? Where is Sashi? You are okay? Yeah. नहीं अभी खाना है बोला So आप लोग चले जाइए टेबल के पास बारी बारी से. Any one of you all? Conventional method of disc sulci. It is easy to do in your OPD setup also. Any of the this.
Please maneuver.
No, sir, we are coming to the treatment. We are not even gone to that. We are just diagnosing right now. We don't know if the patient is having BPPV. We are just checking it. Every manner of treatment हो जाएगा sir. How do you perform a disc sulci? One is a conventional method, one is a sideline method. And why such? That is equally important because we are going to answer how can you check in a patient who is an obese or is pregnant. Okay? So now not much people are aware. So the conventional method would example. The patient sits in it has to be the 1/3 zone. Okay? You can take them, adjust them, but when they sit it has to be 1/3 because that's going to be the spine area. So the conventional method is fold your hands, turn the head 45 degrees and take the patient down and wait. And this is how you check and pick. Okay, and you will hold on. And then you take them up.
First turn the head towards 45-degree angle. In second.
For your understanding, turn like this and take them down, but hold them. Now take the no, but you're on the bed, you're not this. नहीं, ऐसा नहीं. पहले ही turn कर लेना. See, do like your हाथ से करो. Turn like this. See.
Keep your legs straight. First turn the head towards whichever side you are suspended.
And like this.
Then you turn it 45 degrees, let it go down 30 degrees in extension.
Understood?
No,
Understood?
There should be no fixation of the
Problem in that dorsal-lumbar region, or they have a pain when the movement in the this region, you know, you can always think of this. A patient who is pregnant, a patient who is very obese. Okay, you can think of this. So, this is, you turn his head like this and take them down, bus. This is sideline method. Okay, I will go behind and I will again do it. Like this. Now I am checking the right, I will turn it to the left and take it down. Okay, and I have to look for this time, you can fix it again. But not 90 degree. Don't do a Gauffoni, do a 45 degree. Okay, so this is a difference. Posterior canal. Clear? Clear na?
Yes.
Yeah. Now comes, I will go with anterior canal first because anterior canal is relatively easy. So now you will ask the patient, इधर बैठा हूँ जैसे तुमने बोला था. Now again fold his hands and now we are checking for anterior canal. So take the patient straight and head hanging, eyes open. This is the assessment for anterior canal. This is not a maneuver. This is diagnostic test. समझा? Diagnostic test और इसमें फर्क है. Okay? Now we will do horizontal canal. Now the chin tuck, because that 30-degree angle should be coming. Because when you make the 30-degree angle, then that horizontal canal will come up. Okay, and then you ask the patient to turn on one side and fix. And you also bend to check what kind of vertigo it is. So if it is going this likewise, it is geotropic, going towards the ground. If it is going up, it is ageotropic. Geotropic मतलब जमीन की तरफ, धरती, and against the धरती, that is ageotropic. Okay? And then if you want to assess the left hand, then immediately like this and do assess. And then straight. This is your supine roll test. So first for disc sulfide, two methodology, supine roll and deep head hanging for anterior canal. Clear? Okay. First two step of your maneuver. क्या समझा? जो पहला दो स्टेप आपके चेकअप का है, उसके आगे के तीन स्टेप उसका मैनूवर है. कोई भी आप पकड़ो. Be it disc sulfide leading to Epley, conventional leading to Simmons, deep head handling leading to Yakovino's maneuver for anterior canal, and geotropic, ageotropic leading to barbecue roll maneuvers. It is from the same this. So whenever you are testing and if you are pretty confident, you can go ahead for the maneuver. But I always recommend assessing all the 6 canals. 2 on the right, 2 on the left. 2 years, 1 year, 1 year. 3 pairs, 3, 3. Total 6 canals you have to assess. Only in anterior canal, you don't need any specific assessment of right left because you are going together. Clear? Okay. Now some demonstration from my Yeah. So now see, he is checking. This is supportive method. Here is Dr. Richard Cairns is assessing the left side posterior canal. See how he is supporting the back. So he is assessing 45-degree turn and he has supported the back. You can do it sideways also, and you can do the way I have told also by hanging it. We generally prefer doing hanging it. But the physiotherapists are more very nice with the patient, more warm. So they are ENT surgeons. आगे बोलने की जरूरत नहीं पड़ी, ठीक है? So it's like that, you know. Clear? Is your friend? I made that angle 45 degree. How? I asked them to do the workup on the neck. Then I got that angulation and I was able to perform the maneuver. Of course, the initial, because itna din tak he had this dysfunction that he had kept his head only tilted. So you cannot change that habit. So some physio, some activity, later on you were able to perform the maneuver. Okay. This is a recorded video taken from YouTube for your understanding.
Essentially, the head is moved in such a way to manipulate the crystal to fall towards the...
So this is a crystal. Don't go on the nystagmus. This may be a bit confusing, but see the movement in the endolip.
For the crystal to settle into the most dependent position in the canal. If turns are made before the crystal has a chance to settle, the crystal may fall back the wrong way and in a new...
Okay. So he is the technical head and he is performing on physiotherapy, but there will be slight angle on the fourth step. So don't get worried. It is just that the body, the structure of the anatomy is different. And then Indians are more way healthier. You will not have a very slick personality like this female. She is also a doctor basically. So they are doing it to demonstrate how it is. So those who are well versed in FP will find it different when their movement is from the third to the fourth step. But actually it is one and the same only. Okay. They are doing a bit of supportive techniques. See this. Now this is on the right side. This was I think left in the left.
Right.
Low heighted bed, very low. So this generally is available in the physiotherapy forte because it's a very low line and see he is actually sitting down and doing this. The advantage is that the space, the spine, the neck pain. That is not the criteria for doing this maneuver. In fact, you can just, choice कर सकते हो आप जिनको है, क्योंकि उससे वो चद्दर से इसको खींचेंगे इस तरफ. So your second and your third and the fourth step gets combined of place in this particular maneuver. See, but not practically possible for us in a busy OPD to do this kind of maneuver. So there are some ifs and buts. And basically if you see in all the maneuvers there was one position where they moved the head, that is to avoid canal jam. So the canal should not get jammed because of the crystals. That is why you do it in the second last step before making the patient head up. That will be in all the maneuvers that AIB does to avoid canal jam. Okay? Fine. Which video? So that should be done. Because some patient may understand, some may not follow your instruction. And don't do the maneuvers alone. At least see generally what happens, one end of the bed should be with the ball and two ends should be free for you to move or do the maneuvers. So generally two assistant plus the one who is going to be the lead. So three people should be there. And immediately don't tell the patient, हो गया अभी आप जाओ. ऐसा नहीं है. They will fall. They may have drop attack there and there. So make them wait and get them nicely inside your OPD. Make them sit and then give the instructions. राइट के लिए तो आप राइट से शुरू करके लेफ्ट में जाओगे, लेकिन पेशेंट ने बोला मैं लेफ्ट से राइट किया. सो ऐसा नहीं कि लेफ्ट के लिए भी वही फंडा है. नो, लेफ्ट के लिए यू स्टार्ट फ्रॉम द लेफ्ट, राइट के लिए यू स्टार्ट फ्रॉम द राइट. ओके. Maneuvers have an excellent prognosis and that's the gold standard of treatment. And vitamin D deficiency should be corrected. So 60,000 units once a week for 8 weeks is minimum. Then 2 हफ्ते में एक बार you should be giving it आगे चल के. And look for other conditions if the maneuvers fail. Means it is something else that you have not seen. So this is with BPPV. So let's do some hands-on. So I am coming to each of the tables. So first you all will show me the side lying and the normal. Like this. This is the right side I'm taking.
Correct.
Why? Because the right side is getting gravitated. No?
Towards that.
Yeah. Towards the gravity. No? You are following the evolved. And for the left. Correct? Understood? So this is the sideline. Now the conventional method. That is the conventional method. This was the sideline method. Sideline is more of supportive method. आगे आगे नहीं पीछे वाला. Tooth one side, tooth third. Now fold your hands. Come behind more. Come behind more. Then again, see, I always explain the procedure to the patient before starting it. उनको पता नहीं चलेगा कि आप क्या कर रहे हो, डर जाएंगे हम लोग, चिल्लाएंगे तो अलग से, they panic. So explain them. See, we are checking it, we want to know on how things are. So you turn and take the patient down like this, okay, and wait.
Do we have to stretch the neck?
No, support. You are not giving a cervical traction, na?
When it goes down.
स्पीड आने वाला है ये उनको भी पता है, और उनका डर रहेगा फर्स्ट वाले में, तो वो टाइम पे स्पीड बढ़ाते तो आगे का 4 चेक होने से, तो वो pretty when you doing the first one. Finger, your finger should immediately come up. See like this. Now also fix it. इधर देखो. Yeah, you can do it from the head. I'm demonstrating that. I generally do it from the head. I generally prefer doing it. I do it like this. I do it actually like this and then I put it. Yeah. Becomes easier. But ठीक है, नहीं बटा तो आपको करना ही है. ठीक है, तो I generally prefer doing posterior canal, then horizontal canal, then anterior, or posterior canal, anterior canal, then horizontal canal. Some of my colleagues prefer doing horizontal and then posterior canal, anterior canal, but I prefer posterior and anterior. को posterior canal में बहुत सारा information है. Horizontal आया, nystagmus मतलब actually it is horizontal canal VPP. और downbeat आया, मतलब it is anterior canal VPP. तो I started posterior canal. That is my.
And we start with the better ear. If we.
Not necessary. If you are very confident, start with the affected ear. Why wait?
Madam, you may do this way and then you have
Side and you ask him on the left, same way. But not from the right to the left. You are not doing the maneuver.
Yeah.
So it will be one by one. Horizontal way it can be done together because they are in the same canal. But not here. So get a pillow now and I will do horizontal canal. So इसमें post plexus pack will be 1 and 1. Now आगे जाओ, because of the flow of the canal and the excess they are present there. Now लेटो, ये flat है, इसमें कोई लटकाना नहीं है सर को. There will be only 30-degree angulation. Then check it. Yeah, so see here. So now you will check here supine roll. This is for horizontal canal. And यहीं से you can immediately assess the. तो ये आप सेम सेटिंग में कर सकते हो, उसको मत करो. And
Chin remains stuck.
yes, because horizontal canal is ऊपर. Only in supine roll. ठीक है? उठो.
Supine roll is full 90 turning.
90 right, 90 and 180 degree left. That is also okay. वो पता चल जाता है तो बारी-बारी से. अभी नहीं बैठाएंगे करा लेना था.
So while manipulating the head, that
Checking.
checking.
Manipulation हुआ नहीं है, manipulation maneuver. हाँ.
So while checking, I should be
The way
consistent about the position of the head.
Yeah.
Correct. Na?
So you have to tell them to maintain the 30-degree angulation because the moment you leave it, you will miss it.
You should not move yourself.
The patient should not move. You will be standing intact. You also have to be intact. Your movement will also, so you will also not have vertigo. Okay, so your movement will affect his.
It's a passive test procedure, so you have to give yourself to the therapist.
Yeah. So now again we'll do the last for anterior canal, then you can make yourself like pairs में करके करो. पीछे आ जाओ, come behind. Deep and hanging very easy. पीछे आ जाओ, पीछे. Come out behind. In this it's very straight. Yeah, like this. And just look. Anterior canal. So you'll have to down breathe. And if you're lucky enough, you can determine the torsion. So if the torsion is going this side, counterclockwise, it is right. If it is clockwise, it is left. But side determination is not important, neither in the maneuver it is that important. Clear? Now remember one thing, when you are assessing the right distal pipe, you are assessing the left vertebral artery. That is why sir said that you will gate crash the patient. But actually you are assessing the vertebral artery at that point of time only. So either you flex it, make them sit and flex it, or make them flex it like that, that will not make a difference. So your assessment happens out of the vast procedure. The vertebral artery staining test happens at the time of exercise. Keep this in mind, small group. Now practice this side.